Quality Talks is brought to you by several generous organizations. NCQA thanks Platinum sponsor Merck for an independent educational grant to support this event.
Hi everyone, and welcome to Quality Talks 2023. We're live today from the second floor terrace of the DC Capitol Hilton. Today's event is not your ordinary healthcare discussion. What you hear at Quality Talks is what everyone who delivers quality care will be doing in 10 years, and perhaps even sooner. Today, you'll witness a series of stirring, succinct talks by current and emerging healthcare leaders with ideas about how we can collaboratively improve American healthcare. After each group of speakers, we'll bring you back here to the set for one-on-one interviews with many of the speakers from today, as well as NCQA scientists and leadership. Now, a bit about me. I'm your host for today, Dr. Nick Van ter Heyden. I'm also known as Dr. Nick. I'm an emergency room physician, and I've served in hospitals all over the world. For the past several years, I've become a medical correspondent, passionate with a voice about the positive impact that these new technologies can bring to healthcare. After interviewing so many healthcare leaders and tech developers, I'm looking forward to meeting all of our guests today. Our live stream show will continue all the way through to about 3:30 today. Be sure to plan ahead, stick around, make sure you don't miss anything on the stage. Each of our speakers will have about 15 minutes to speak. It's like a TED Talk, but just for healthcare. No selling, no spin, just inspiring talks for our audience. For all of you, this live stream show provides a deeper dive with our Quality Talk speakers. We have so much to cover today, from hospital at home to health equity to digital transformation, and so much from the NCQA, especially an exclusive glimpse at their new health stratification dashboard. For now, we head over to the stage for our show. This is Quality Talks 2023.
Able to do? This is the work that gives us all hope.
Patients are hungry for honesty in healthcare.
You could have the best innovation in the world, but if you cannot implement it in this socio-technical environment, it's not going to be any good.
I believe that we have the ability to use our imagination to make healthcare beautiful.
We need to expand the definition of health to include life, because when life goes wrong, health goes wrong.
Just because we make a resolution is not enough. We need to change our environment.
Quality is ethics, because working towards the provision of high quality, highly reliable care is doing ethically sound medicine.
Success is about long-term outcomes. It's about our members' health and their community's health, not just the units of healthcare that we deliver.
When you are allowed to select more than one race, none of your race data gets reported.
How is it that the challenge of keeping the lights on at our institutions has somehow become more all-consuming than the challenge of our patients their lights or their heat or their electricity on at home?
Is it that value-based payment, as we've come to know it for the better part of a decade, generate benefits that are more readily available to some people and not others?
Innovation must always meet the criteria of delivering value.
Welcome to Quality Talks.
Welcome to Quality Talks. Here's your host for today, NCQA Assistant Vice President of Communications, Andy Reynolds.
Good morning. We're glad you're here. On behalf of everyone at NCQA, thank you for joining us for our different kind of healthcare conference. For people who are committed to building better healthcare, better choices, and better health, Quality Talks is an opportunity. It's a chance to step back from the day-to-day work of what quality improvement is, and instead consider what's new, what's next, what could high-quality care become. And that is where our dynamic and thoughtful speakers come in. You'll hear today from 10 leaders who will share novel ideas on how to improve healthcare. Their talks will be short and vivid, and we think you'll want to hear more. So, 3 times today, during breaks, we will invite you to meet the speakers in the spaces we've marked as speaker salons. We urge you to go to the salons because the conversations that happen at the salons help you get the most out of Quality Talks. Now, for their part, the speakers are eager to meet you at the salons. They want your feedback on their ideas, and they're eager to continue the conversations that their short remarks from this stage spark or initiate. If you're watching Quality Talks online, during those salon sessions, we will bring you live interviews with a variety of people covering a range of topics. So, while there's nothing quite like being here in person to meet the speakers and interact with them face-to-face, there's still plenty for you to see and learn during the salon sessions, so you'll want to stick around for that. If you use social media, we invite you to let your followers know what you're learning today. Please use the event hashtag, you guessed it, Quality Talks 2023. I urge you to go to the Quality Talks website, qualitytalks.org, to find out about our speakers, get a look at the program. At this point, I'll let you know that I'll be back throughout the day to tell you a little bit about each speaker. And it's my pleasure to introduce someone who made it possible for us all to be here. She founded NCQA in 1990 as a one-person operation working out of borrowed office space. Today, NCQA is almost 400 people who, along with many of you, have helped make quality improvement part of the fabric of American healthcare. Please welcome NCQA's founder and president, Peggy O'Kane.
Thank you, Andy, and thank you all for being here. And I want to give a shout out to, I think, the 800 people that are online. So welcome to all of you. And I'm going to start. Can you put up the slide? I have one slide. This slide is meant to shock you. And what it shows is, you know, we're kind of living with the idea that life expectancy continues to decline in the United States. And one of the things that I think is really important about this slide is you can see that if you look at the comparable country average, they're on the way back up. And that means they're recovering from what COVID did to the whole world. And we continue to slide. And I don't want to say this is the fault of the healthcare system. I just want to say this is the reality that we're up against. And, you know, if there's anything that's kind of a theme for NCQA, it's that we look at the data, we take it in, and then we do something about it. And so I think we need to be thinking about ourselves as advocates for the social forces that are leading to this, and also as driven to improve healthcare and the 20% of American GDP that's going into healthcare for not adequate results. So, you know, Quality Talks is kind of an aspirational meeting. It's about hope. It's about showing what's possible and so forth. But we also have to remember that part of our task is to keep ourselves honest, and then we take the hopefulness and we go out and implement it, and we make sure that we're able to clock improvement. So, and just let me say a few more things about this shocking slide. A lot of this is about early deaths in the United States for people under 50. But even 5-year-olds, their life expectancy at the age of 5 is lower than in comparable countries around the world. So I think that really bears some contemplation and understanding about why is that. 75 and up, they're doing fine. They are not experiencing this slide. So there's a lot behind this, and we need to understand it and take it to heart. So having said that, let me move on to what can healthcare do. And again, I think number one is give better value for the money that we spend and reduce the money that we spend, because the money is being taken from other sectors of our economy, and they're making American workers less competitive in the world. Even though we're trying to bring a lot of jobs back into the United States, this burden that employers face of health insurance and so forth really does hold us back and holds every American back. So I say this, it's hard to face this kind of data. It's hard not to be depressed by it and to want to deny it, but it is our job to kind of fix what our part of this scenario. So you can take the slide down now, thank you. So, NCQA is on a journey to deliver healthcare digitally, and we started out, we were very shocked to hear how many people at the front lines of delivering care hated quality. They thought, this is horrible. I'm having to take my computer home at night. I'm having to enter all this data. Everybody's asking me a question in a different way. And so we took this very seriously. And I want to say, I feel like we're making some progress. So our first move was we're going to digitalize HEDIS. And ultimately, the goal is that the data that exists at the point of care will be used to populate HEDIS, and that quality measurement will flow out of the delivery of care. That may sound like an impossible vision, but there are already organizations where this is happening. The goal is really not to kind of do the gotcha of like, you missed this measure, but to enable people to get it right the first time, to get the information in front of them at the point of care. And the point of care, obviously, is moving. It's not necessarily in an office and so forth. So the digitalization of HEDIS, number one. But as we've been doing this, and by the way, it's not easy, it's hard. We've also, the other thing we've been up against is all the different ways of measuring things, measuring the same thing. So we're so pleased that CMS has published their Universal Foundation Manifesto, is the way I think about it. It's the perspectives in the New England Journal, where they are aligning measurement across the system. So where we used to do a health plan measure, people would then hire a bunch of coders to transform it to the delivery system, introducing a lot of redundancy and waste, a lot of opportunity for human error and so forth. And then it would flow down. And, we've been talking very seriously with CMS about how to make this better for, I think, about 5 years, actually. And so having CMS say, well, we don't want to be part of this problem. We want to make sure that whatever the use case is for the measure, it's the underlying clinical logic is the same, and we're creating synergy and not noise for practitioners. The other thing so we feel like we've got the wind at our back now to do some things really differently. The other thing that has unfolded in front of us is the transformational potential of digitally enabled care, and you're going to hear about that today. You're going to hear it from Bechara, from Kaiser Permanente, from Aaron Neinstein, from others. There are really important breakthroughs being made in the process of care delivery. The other thing that's happening is, we've all come to understand the huge impact that disparities and lack of health equity are having in healthcare. We've been working really hard. We've got a lot of Medicaid programs aligned with us. We're getting to alignment, I think, with CMS. And so that piece is coming along. So I want you to leave my presentation with hope, because what we've got to do is we've got to take the dazzling information that you'll get today, we've got to turn it into our daily work, and then NCQA's job is to hold ourselves accountable for, is this actually working, and then hold you accountable in various ways through our programs. And so that is the formula. And We can't do it alone. There are many, many organizations. We're pleased to have CMS and Medicaid aligning with us in a lot of different ways. But many of you are in organizations that have the ability to help us. And so as we continue on our journey, as we move into an early adopter stage for HEDIS, digital reporting of HEDIS, and as we are evolving our programs to kind of foreshadow, our programs have always been about what's possible and not are we just good enough. So as we try to design these programs in a way that allow entities that get our accreditation or whatever program they're in the freedom to innovate, we also want to make sure that we're getting good information on what's working, who needs to be a role model for others, and so forth. So I love this meeting. I love the audience and the interaction with the speakers in those breakout rooms. They're really probably the best part of the meeting. And so I invite you all to have the full experience today. And with that, I'm going to stop and welcome you and bring on our first speaker. And I guess, Andy, are you doing the introduction? Thank you.
Yes, boss, I'll do the introduction. Our first speaker grew up in Lebanon amid that country's civil war. He immigrated to the United States as a young man. He's lived and led in very different parts of this country, Texas, Chicago, where he was the city health commissioner. When he was here in Washington, D.C., he worked at the White House. He now works and lives in California, where he attracts the attention and respect of many in the quality community for his leadership at one of America's largest health systems. He's seen a lot, he's learned a lot. Today, he's here to share observations about how healthcare infrastructure, big systems, what a difference they can make at the level of individual patients and health equity. Please welcome Bechara Choucair.
Thank you, Andy. Thank you, everybody. It's great to be here with you all to kick off these NCQA quality talks. I'm hoping I can achieve two things today in my 15 minutes or less that I'm spending with you all. One, I want to share with you a framework I rely on that I believe is truly critical to continue evolving how we think about health and equity in this country. So I'm going to share that framework. And two, I'm hoping I can spark conversations in the room here with the audience and then in the quality salons where we're going to be chatting about this a bit more, about how adopting that framework would help us think differently about quality and how we can continue the journey towards quality. So let's start with the framework. Every person I talk to in the healthcare space today tells me how much of unprecedented, challenging times we live in. Pretty much everybody I talk to. And when they say that, that means we have to be thinking differently about what we're doing. That urgency, that unprecedented challenges requires us to think differently about how we continue to evolve, continue to transform healthcare in this country. We saw the slide about life expectancy. We spend more than twice than the average high-income country in the world when it comes to healthcare, and yet our health outcomes are not nearly there. Our life expectancy, as Peggy mentioned, continues to be a challenge. And we have a lot more to do. And that's why the framework I'm going to be sharing with you today is about optimizing health and equity at three distinct interconnected levels. How do we think about individual health? How do we think about community health? And how do we support public health? These are three distinct levels, but they're so interconnected, and we have to think about them in that same manner, at the same time, interconnected and very clear focus to be able to make a difference to help us optimize health. So I immigrated to this country in the late 1990s, and I trained as a family physician in a healthcare for the homeless program in Houston, Texas. And I spent a lot of my time working with people experiencing homelessness, with immigrants, refugees. And I remember Ray. I met Ray in one of my very early days as a family physician intern, practicing in a homeless shelter in Houston. And Ray was in his mid-50s. It was his first time becoming homeless. It was his first night at the shelter. And I had just learned all about preventive measures and how a person in their mid-50s really should be getting screening for colorectal cancer. So here's this intern who just immigrated to this country, sitting with Ray, having these conversations for minutes and minutes and minutes of me trying to explain to Ray why it's important that he gets his colorectal cancer screening. And Ray was just so quiet, just looking at me, then he's clearly uninterested. So I paused and I'm like, what's going on? And he just looked at me and he's like, dude, what is it that you're missing? This is my first night being homeless. I'm incredibly embarrassed. I'm sleeping here with so many other people. I don't know where I'm gonna be sleeping tomorrow. I don't know where I'm gonna get my next meal. And you're talking to me about screening for a potential disease I might get years down the line. This is not what I'm caring about right now. And I think about this conversation often. 25 years later, I think about this conversation so often. And that brings me to that very first pillar of that framework, which is focusing on individual health. It's so easy for us in health systems to think about individual health as focus on physical health or focus on mental health. And I'm here to share with you that's not enough. We have to be thinking about the social health of our patients with the same way and the same rigor that we think about their physical health and their mental health. And here's the journey that we've been on at Kaiser Permanente. We are building a social health practice with that same rigor that we've built our physical health practice, our mental health practice, and we're incorporating that in an integrated fashion, the same way we deliver care every single day for our 12.8 million members. That focus on social health needs to become an integral part of how we think about health and well-being in this country. So what does that look like? Well, what that means is, one, we have to be able to have the infrastructure to be able to screen for social need, document the social need, connect it to our electronic health record, and make sure that we do that as part of our day-to-day operations. That also means the same way we have a network of primary care providers and specialists to take care of the physical health of our members, the same way we have networks of counselors and therapists and psychiatrists to take care of the mental health needs of our members, we have to build these networks of community-based organizations that will be there to support our members with their social need. And we have to be able to connect those CBOs into our electronic health system so we can have that back and forth conversations, we can have that follow through and be able to close the loop when we refer patients to make sure they're getting their social needs met. That's what it looks like to build that social health practice with the rigor that we need. And that's the journey that we've been on. So here's that first pillar. We think about physical health, mental health, and social health. We integrate them all together to get us into how we optimize the health for the individual. But make no mistake, this is not going to be enough. And if you start screening a lot of people in your practices about their social needs, you'll quickly realize that a lot of them have a lot more needs, and we have to be able to figure out how to connect them to services. And you quickly realize how important is that second pillar of the framework, which is community health. So what is our role as health system in advancing community health in our communities? And look, Ray is going to be as healthy as the community he lives in. Let's make no mistake. We have a significant role to play as health system in advancing health and well-being and health and equity in the communities where our members live. So, Ray has a need for housing. We can connect Ray to an organization that helps them with transitional housing. If Ray has a medical emergency and needs a place to stay, we can probably connect them to a respite program, and that would be great. But the reality is, engaging in our communities requires systems change. There is no way we can improve health in our communities unless we think about policy change, systems change, environmental changes, and health systems have a big role to play, to bring their voice, to bring their resources to be able to make a difference on policy systems and environmental changes. So let's stick with the housing issue for now. So there are many organizations in our communities that would be able to support Ray with his housing needs. In most instances, these organizations are under-resourced, they're underfunded, understaffed, and yet they're funded through different channels, and there's lots of silos in the community-based organization space. So imagine as a health system, you could partner with an organization, a community-based organization that helps you get real data on homelessness, and I mean real data, by name data in your community, helps bring a unified framework of how to be able to match people with resources in your community and be able to generate reports on the progress you're making, real life progress, real-time data to help you understand if you're making a good progress on that, and helps coordinate the efforts in your communities. And that's what you can do if you think differently about how you engage in your community at a community level. And that's what Community Solutions, a partner for us that we've been working with in 30 communities across the country, is able to now see real reduction in homelessness and different parts of homelessness, whether it's a veteran homelessness or chronic homelessness, in 14 out of the 30 communities that we're working in. That's the type of engagement in the community that could make a difference. You can also think about engagement on leveraging your Treasury Department to invest in projects that preserve or add affordable housing units in your communities. We're on a trajectory to add or preserve about 30,000 affordable housing units in our community. You can work with organizations that advance policies to promote housing and affordable housing in our community. We're a founder and a partner of City Health that is working with 75 cities across the country, the largest cities, to adopt those policies. A lot of things you can do differently when you think about your role at a community level. So we talked about individual, we talked about community health, but that's never going to be enough unless we are supporting our public health system in this country and in the world. I had the privilege of serving as vaccination coordinator for President Biden in 2021. In a few days, we're going to see the end of the public health emergency in this country. And I'm incredibly proud of the work that we've done on vaccinating this country. By the time I left the White House, we've administered nearly 500 million shots of the vaccine across the country. And we've done that by eliminating also disparities in vaccination rate between races, in race and ethnicities across the country. I'm incredibly proud of the people I met throughout this year. There's Felicia Thibodeau, who ran a small not-for-profit organization on the southwest side of San Francisco, where she single-handedly would go and knock at people's doors and work with people who have questions about the vaccine, get them in her 15-seater minivan and get them to get vaccinated. And she got 1,271 people vaccinated. The country rallied so well to make a difference when it comes to ending this pandemic. And yet, when we think about the public health infrastructure today, there's so much need there, and we have a big role to play in making sure that we're optimizing our public health infrastructure as a country. That's why I'm really happy with the work that we're doing and the coalition that we've launched with AHIP, the American Medical Association, and the American Hospital Association, to try to figure out how we optimize the interface between public health system and healthcare delivery systems. We have to be able to better understand the data flow in that space. We have to be able to better understand what each part of this health system's responsibility when it comes to emergencies. How do we create contracts and agreements between healthcare delivery systems and public health agencies so that we are prepared when it comes to public health challenges that we will absolutely continue to face throughout our lives. So thinking about the role of the interface between public health and healthcare is so critical, and I would encourage you all to think about how we can continue to advance that, and the coalition with the AHA, AMA, AHIP, and ACHP will hopefully try to do just that. But even that's not going to be enough. I've seen it firsthand during my tenure at the White House, the interconnectedness or the interface between the public health system and our community-based organization is a bit clunky and needs a lot more work, so we have to continue to optimize that. So I'm also very happy to see the CDC Foundation leading an effort to try to help us understand how do we interface those two industries a lot closer, your community-based organization and your public health system. And we have to think about how we continue to optimize and honestly develop and disseminate a public health research agenda for this country. So we are also working with Academy Health and some leading public health universities to think about what role we can play to help develop that public health research agenda. So that's how I would encourage you to think about these three areas, the three distinct yet interconnected pillars of how we advance health. What can we do to continue to improve on individual health by incorporating social health as an integral part of how we deliver care? How do we think about our role in advancing conditions for health and equity in our community? And what role do we have to play to be able to truly interconnect with the public health system and support the public health infrastructure in this country? So as you think about what role quality has to play there, imagine what would quality metrics look like for individuals that goes above and beyond the traditional constructs of measuring for process, but truly think about outcomes, not just for physical health and mental health, but also for social health. How do we think differently about quality measurements for our engagements in the community, which is absolutely critical? And what would quality look like for the way our healthcare systems interface with our public health system? I'm incredibly hopeful and excited about what that future might look like. And I know that the folks here in the room and the folks in the online have a big role to play to create a better future for everybody. So thank you so much for having me here.
Our next speaker is what I think of as a full spectrum thinker on AI. What do I mean by that? Well, she's earned accolades in academia and industry for her theoretical and practical contributions to the growth of artificial intelligence. And yet, at the same time, this is very rare for a technical expert, many people in this room have had the experience, told me, they just a few weeks ago, we're in the car listening to NPR, and someone was making a very clear and interesting, accessible explanation of artificial intelligence. You get to the end of the clip, who is the interviewee? Our next speaker. Please welcome Suchi Saria.
Will you raise your hand if you're sick and tired of hearing about AI? Well, if I'm here, I have to talk about AI. It's hard for a day to go by these days without a headline about AI. Just on Monday, a big one that captured many people's imagination was Jeff Hinton, one of the most respected researchers in AI, resigning from Google. There were many reasons why Jeff resigned from Google, but the sensational piece that made it to the headline was him resigning, warning about the dangers of AI. I'm personally very excited for Jeff to be now able to freely work on AI safety without worrying about the corporate structure of Google. Now, controversies and conflicts often make for great headlines. You don't get to hear as much in sort of a desensationalized way. What is this technology? How does it really work? And what good is it really going to do? So that's going to be the focus of my talk. Let's go a little under the hood. So how does AI actually work? What is AI? How do we make these programs smart? I'm going to start with a really, really simple example. Let's imagine you wanted to train a computer to play a game. How would you train a computer to do that? So the first thing we do is to design what's called the goal. So in this case, it's winning the game, and often that translates into something like score a lot of points, the most number of points, right? So step one is defining the goal. As designers of AI technology, we often define that using math. So in mathematical language, we can say, maximize this goal of scoring as many points as possible. Now the next thing is moves. What moves can you make? So in a game, often you can go left, you can go right, they're viable moves. Once it knows about the moves, then the third thing is essentially scores. Each move is scored. A move that is a good move that helps you win the game gets you a positive score. A move that is not a good move, it's a bad move, and you lose the game, gets you a negative score. And now what the AI is being asked to do is to write a program where it builds and learns models to predict what's the next best move, and as it predicts the next move, it gets a score. And if it's a positive score, that's like a positive reinforcement, and it wants to do more of it. And if it's a bad move, it gets a negative score. And it does that millions and millions of times in order to uncover good strategies for winning the game. And effectively, by the end of this, and it can do so by either asking from experts, it can do so from taking past data, it can do so by exploring and experimenting and playing games with itself, it can do so by experimenting, exploring, playing games with other experts. But using this approach, very simple approach, we can train a model to intelligently play a game. And that's really the same underlying approach and technology that's being used for designing cars, designing chatbots like ChatGPT, and designing solutions within healthcare. Interestingly, in 2016, the game of Go is considered to be a very, very hard game. We didn't think it was going to be possible for computers to beat human experts. In 2016, we showed a computer program called AlphaGo that beat Lee Sedol, who was one of the world's reigning champions in Go. And when Lee looked at it and commented on the computer's performance, he said it was shocking to him how the computer had uncovered strategies that human experts had never thought to explore before. And therein lies the power of AI, the ability to use data, an unbiased way of coming at the problem and exploring ideas to find novel solutions. For exactly this reason, when you go to ChatGPT and ask it to write a love note or ask it to write a poem, it creatively constructs new plans. So you might be wondering, okay, this makes sense. Now, how is this ready to go for healthcare? Can we use it in healthcare? Is this a thing of the future? Now, it turns out there's actually very many practical ways, and there are already projects underway that are being used in healthcare. I'll describe an example effort that we started almost 8 years ago. So this is while at Hopkins, I started this big initiative around using data in the electronic health record to design AI strategies to start predicting patients at risk for preventable harms. The idea being, we know so much about the patient, couldn't we collect all this data and use AI to identify novel strategies for identifying patients at risk for a variety of different harms? And doing so would allow us to move from reactive care models to proactive care models. So an example of a harm like this is sepsis. I lost my nephew to sepsis. He was only 26 years old, and when he was in a state of septic shock, his sepsis was discovered. Unfortunately, he didn't make it. Sepsis is very well understood in the community to be an area where we know early identification can really make a difference. But the challenge is identifying patients accurately and early enough. So this is where we first pointed our technology. I'm not going to talk a whole lot about how we put this method to use in sepsis or the barriers we had to overcome to be able to both solve the problem but also then implement it in a way that providers would adopt and implement it in a way that it could be disseminated across hospitals around the country. I have a whole TED-Med talk focused on that if you're curious. But what I do want to talk about is these results that I'm exceptionally excited about. So last year, we released 3 manuscripts that were on the cover of Nature Medicine. It literally took 8 years of work to get there. And these results were groundbreaking for the field and for a number of reasons. So the first thing they did was, these were very large studies. They were across 5 sites, academic and community hospitals, almost 750,000 patients in these studies. And here what we did was we took the platform and we deployed it across these 5 hospitals over a 2.5-year period. The first set of results it showed was the ability of the platform to identify patients at risk for sepsis early and accurately. For instance, we showed that during the hospital stay, when the platform ran in the background, almost 5.5 hours early, the platform was identifying patients at risk for sepsis early against standard of care in patients who otherwise died in the hospital with sepsis. Now, these are some of the sickest patients where there's maximum opportunity for early intervention and improving outcomes. The next question we explored in these studies was people will say, yes, you can develop the technology. But the question is, will clinicians, will providers adopt it? Because many providers think AI is this gobbledygook, scary thing. Now, interestingly, this area of research is called human-machine teaming, which is how do we build solutions in a way that allow for better teaming between humans and machines. In other words, the two together is better than one each alone. And so after a number of years of research where we made advances on a number of different topics, we were able to design these solutions in a way that really were seamless, easy to use, explainable, and enabled collaboration and teaming. And in these studies, what we saw was almost 90% physician adoption. 90%, and this is 2,200 physicians participating in these studies over a 2.5-year period. And this is, when I say adoption, I mean when the platform flagged a patient, providers would go in, click, look at the results, analyze, and enter an evaluation. And so we had an accurate early identification, we had participation. We also then did an outcome study, and it was a pragmatic study, where we were then able to show that when providers came in and actually intervened early, as you would expect, we saw differences in improvements in outcomes, significant reductions in mortality, morbidity, length of stay, and a variety of other markers. And sepsis is only one condition. This is applicable to many other condition areas. And as part of my company, Bayesian Health, which we spun out of Hopkins, we're now partnering with health systems around the country to make it very, very, very easy to implement systems like this in a safe and responsible way. So, because you're all here in the room, you're in a very unique position to be able to help if you found the ideas I just described intriguing. First, we can't improve what we can't measure. We need better measures of quality. And when we say better measures, like we just heard the previous speaker said, measures that truly reflect outcomes, truly reflect quality. And with electronic health records in place and all the data elements in place and modern technologies that really allow us to parse and understand the data, we can design much, much higher quality measures that truly reflect reality. Second, now, I think today when patients go to the hospital or for access care, they pretty much go where the ambulance takes them. They don't think very hard about quality, right? And is there a way we can elevate the role of quality? It's hard to say this in this audience because you've probably each put in decades of work into elevating quality. But I think there's such an opportunity here to leverage modern social campaigns and things like that to really make quality front and center. Imagine if patients individually understood the impact of better quality care from one site versus another site on their individual health. But also if they could truly have this data available at their fingertips in a way that they made decisions with it. Now, some of my colleagues, when I talked to them about this, they said, Suchi, we already, quality already, there's a big incentive for quality. We already care about quality. I don't think that's the issue. So I was like, what's the issue? So he said, the hard part is delivering quality care is very expensive. Doing the right thing today is just hard. It's very expensive, and with our very, very low margins, it's just a hard thing to do. I thought that was a really sincere remark. And so this is going to be self-serving, but the third thing, and really sort of one of the most interesting things that came out of me thinking hard about this, was that I actually think AI can make it possible for us to do the right thing more easily. In fact, I think AI done right will allow us to make the right thing cheaper and easier to deliver. So let me give you an example. So in this example, when we have systems running in the background, analyzing patient data, and surfacing markers right within workflow for a number of preventable harms. For example, patient at risk for sepsis, making it really easy to identify. Obviously, it has to be done accurately. Obviously, you cannot create alarm fatigue. But if done right and done well, you're less likely to miss a patient. You're less likely to miss a critical moment. So that's an example of making the right thing the easy thing to do. Let me give you another example. Let's imagine a patient is being discharged. There's all these different needs you have. Today, the data is siloed everywhere, and it's hard to know at that moment in time, both where they need to go and what they need for that to happen correctly. Again, here there's an opportunity for systems, AI systems, to analyze this patient's record from this encounter, past encounters, cull the relevant data, make it easily available in a way so that it's very easy to know both what they're likely to need and what intervention should be given. Another example of let's make the right thing the easy thing to do. So if you'll join me in saying it with me one last time, let's make the right thing the easy thing to do. And that's what I think we can do with AI, that I think will be the big differentiator in the next 10 years. Thanks.
Our next speaker has worked for health equity in many environments over his distinguished career. Aetna, CVS, 2 presidential administrations, both Republican and Democrat. And now he's working for health equity at the largest scale imaginable, the World Wide Web. He's with YouTube and Google. He's in charge of making sure that everyone has equitable access to evidence-based information to drive their healthcare choices. Please welcome Garth Graham.
So when I open my mouth, the first thing you'll notice is my accent. I am Jamaican in so many ways, which includes why I was late today. But I'll tell you that that has a lot to do with my kind of life experiences and what I'm going to talk to you a little bit about. So despite my kind of career trajectory, where my life started was nowhere like this. You know, we came from Jamaica and we moved into some challenging parts in terms of where we live geographically. And life wasn't great when we first started, but my mom took the best care of us. I love my mom. And one of the things when I first came here to the US that kept happening was I kept getting admitted to the hospital with these asthma attacks. So, you know, I'd be at home, then all of a sudden I'd start having trouble breathing. And my mom, you know, I just remember that look in her face. She'd be so worried. She'd be, you know, appropriately concerned. She'd try what she could. She would take me in. They would fix me up. Then later on, I would, you know, a couple of weeks later, it would happen again. It kept happening in a recurrent manner. And the thing I remember about that the most was just that scared look on my mom's face. Just, you know, because she's the center of my world then, and she's now, along with my wife. I have to throw that part in there. So one of the things that we found out was happening was there was mold in our house. There was mold in the house that we moved into, and that mold was serving as a trigger for my asthma. when, after multiple kind of visits between our community health center, the hospital, and kind of figuring this out, we went and my mom was talking to one of the local ladies in our community. Her name was Miss Maggie. And Miss Maggie she was like, girl, there's mold in the house. And she started breaking down everything and she started talking to my mom. And what we found out was for months, folks from the public health department had been coming around and putting flyers in mailboxes and had been trying to kind of tell people about what was happening. But nobody heard, nobody listened, nobody understood. And I want you to remember that last part of what I said when I said nobody understood. What was happening in our home, what was happening in our community was literally killing me and could have stopped me from having this presentation I'm having here today, not just my overall trajectory in life, right? And so it was vitally important, that piece of information in terms of understanding what was happening in our home, but it wasn't getting to us. Even though people were trying, it wasn't getting to us. And that's where this concept, and a kind of something I believe very deeply in, this idea that information is a true determinant of health. The idea around information, not just generic information, how we produce it, but how we reach people, how we engage people, how we pull people in, how people understand it. What was happening in terms of my life story is there was a bunch of well-documented studies around our neighborhood. There was all kinds of very fancy papers. There were very well-done flyers. There were very well-meaning people, totally missing the audience that meant the most. And it almost costed me my life. And so for me, I've really always been obsessed with this concept of not just social determinants of health, but understanding all of these other determining factors that really drive health outcomes. And what I really want to talk to you about is this idea that information that reaches people is a genuine, true determinant of health, and it drives outcomes on a minute-by-minute, hour-by-hour basis across communities, across the world. I'm going to talk to you a little bit about our experience at Google and kind of some of the things that we're working on. But if there's anything you walk out of here thinking about, just remember this concept. How we reach people is really what matters. So let me kind of give you another kind of example. So I'm a cardiologist now. And it's always interesting to me, in addition, I still practice a little bit, and practice through a number of years. It's always interesting to me the complicated information we give patients. So we tell people with end-stage renal disease, don't forget your creatinine, your GFR. What about your hemoglobin, your hematocrit? What about your RDW? And we say that, we give it to them in a variety of different forms, and we say, this is patient-centered care. Here's information, figure it out, you'll do better. And not even medical students understand these concepts, right? Not even doctors understand these concepts. But we expect people to kind of digest these complicated pieces of information and be able to take action and be able to move on these things. And this goes back to this concept of how we deliver information to people in a way that's actionable. What we've been really obsessed with, my team and our broader Google Health efforts, is really this concept of information driving health outcomes. We have the privilege of reaching billions of people along their health journeys every day, every minute. In fact, I often ask people when I go into a room, if any of you woke up with, making up random symptoms here, blue toe and achy ankle, what do? You Google it, thank you, right? That's exactly what you do. All of us do that, right? And we don't do that here. People do that in India. They do that in Brazil. They do that across the world on a minute by minute. The journey that they start around their healthcare is not when they show up at your hospital. It is not even when they call you as a clinician. It is way before that. It's when they wake up with that question in mind. Also interesting, on the opposite end of that journey is when a lot of times our patients leave our facilities and they go home. They wake up in the middle of the night. They have questions. They don't call the doctor. They're not going to get you at 1 a.m. to that question that they were like, well, I wonder what about that thing he last said. Nope. They enter a deep journey online where they research all kinds of information. They look text, they go to video, they go back and forth. And that is the real concept of patient experiences once you have access to technology. And that's one aspect that we should never ignore. But that's one aspect of the patient journey. We don't pay enough attention to that concept when we measure quality of care. We think that, and we measure, and we focus on that journey that is across, a clinician dyad along with a patient, or that hospital experience, which we do a really good job measuring, or we measure that clinic experience, and we say, boom, that's patient-centered care. And what I'll say to you is that is the end spectrum. Again, going back to my example that I started off in our own life, that is the end of the spectrum of that journey. That journey started way beforehand at home. That journey started when, again, that person really kind of entered into that question around what to do next. We have the capacity to reach people. We have the capacity to empower people. But to do that, we have to think of information in three particular ways. We have to think of information that's accessible. And right now, technology allows information to be accessible in so many different ways. We have to think about information that's engaging. That's where we get uncomfortable. We're like, hold on a second, that's not my job. Our job is to just publish some really good papers and put it up on a flyer and a billboard, and somebody else will figure it out, right? And so I often say the days of flyers and billboards of reaching people, not anymore. Right? People are looking for more engaging information in very real ways. We feel uncomfortable in healthcare around thinking about how we genuinely reach people. We describe it in terms and terminologies that are healthcare-centric, not genuinely people-centric. And when I think about Miss Maggie, who helped inform my mom about what was occurring in our community, she was an old-school influencer. Right? She was somebody who was influential in our community, who was reaching people with health information. When we think about how we empower people like that, either through technology or otherwise in our communities, that's really this concept of engagement. And the last thing we have to think about, and when we think about this whole kind of trifecta, is this concept of credibility and evidence-based. I spent a lot of time in my career publishing papers. I have since found that to be less rewarding. And why is that? Whether the p-value is significant, or whether the Kaplan-Meier curve goes one way versus another. That's interesting. What's really more important is what if I could reach one person who understood that information in their journey and made the right decision next. And that is kind of what our team has been obsessed with. We've been looking at this concept. We have the capacity, particularly at Google, in terms of how we're able to reach people. My team works a lot on this concept of video. 2 billion people come to YouTube every month. 2 billion people. The world only has 7 billion or so people? 1/3 of the world's population is engaging with us on a lot of these journeys. So between the assets we have, we know that we're able to motivate and reach people. And we already know that that's where people are. And so what we've been doing is really creating this architecture of patient journeys and how we use, search, video, all of these concepts to help improve people's lives once they have technology. And I want to be clear that these are concepts that apply many times, especially in more westernized world in terms of technology. And so we have to also think about the aspect of how we bring technology to communities that don't have access as well. But the thing to think about here, and the thing I want to leave you with is, we have to get out of our comfort zone. We have to think about the genuine patient journey, not the ones that we can ascribe and measure in our old school way to say, they showed up at 9 a.m., then they went here, and then they got a prescription. It's also interesting to me, the percentage of people who fill their first prescription for hypertension. Only something like 40 to 50% of people even fill their prescription. So we go through this whole concept of saying, you have high blood pressure, here it is, here's a script, see you later. Without realizing that when people leave that office, they have no intention of doing what we just instructed because they weren't engaged in that journey, right? They weren't a part of that. We felt we delivered the information and they left. But what we left them with was not an overall picture that allowed them to be a part of it. And so our concept, and really a lot of what we've been working on, again, is this idea of how do you have information, engaging information, be part of the patient journey? How do you make sure that you reach people where they are? How do you make sure, again, that information is accessible, engaging, credible, and science-based, but making sure that the science that we're delivering is not the science that means a lot to us, but it has to mean a lot to the person that's receiving it. It's been fascinating to me doing this around the world and understanding the difference of how you do this in Indonesia versus India. How do you do this in the UK versus France? How do you do this in the Bronx versus the favelas in Brazil? And just understanding the real global concept of reaching patients and patient engagement. And the fascinating thing that I've learned is patients are already there. Many times we just need to be where they are. It may make us feel a bit uncomfortable. We'll be like, oh, 1 second, that's not my job. My job was just writing the script and I'm out of here. Or my job was just measuring what day they showed up for their appointment and if they got readmitted. I want to say our bigger job is being part of an ecosystem of health information that emphasizes engagement and measures engagement, that emphasizes this idea of how we bring credible information to scale, and then the concept of quality takes on a very different lens. It's not quality based on what you or I say. It's quality based on the individual that's receiving the information. So what we're trying to do is to make sure that we evolve this in a way that's also science-based and replicable. We published an interesting roadmap with the National Quality Forum and a group of other folks to really think about how you think through these concepts through the traditional lens of quality. Though you've heard me say multiple times, that lens needs to evolve. We need to evolve, and that's what caught us off guard with COVID, right? A lot of our information wasn't reaching people in the way that we thought it was reaching people. And so thinking through how we do that in a proactive way, not just for the next pandemic, but for hypertension, diabetes, colon cancer screening, how we do that for the day-to-day lives of people just like me. And when I say me, I'm not saying just the me here, but the me of old as well as the me of new. How do you reach people in a way that means something to them? So the concept and what we've been finding to be particularly successful are these partnerships with individuals who have the knowledge, but also being able to translate that in real world settings to folks around the world. The very interesting part of it that, again, gives me the most inspiration is the reception. You know, you start to see where people breathe a sigh of relief, understanding that science that means something for them actually means something for them. And that idea is something that we often lose when we try to educate folks about health, public health, and science at scale. But that's what we're going to need to do to keep individuals engaged, keep communities engaged. And I would end by saying, potentially, think about how we're saving lives in a minute-by-minute manner. We have to move past the walls of where we are and move into living rooms, move into bedroom conversations. Where I come from, move on to what's happening on the corner, when people are talking in the corner. And how are you getting information to people that are part of their lives, not having them think of how they're part of our lives. And that ecosystem, that healthcare ecosystem that we create when we finally get there, is one that'll have a blended architecture of information sharing in a bimodal way. And that's the future. You know, I think of what we've heard about today. We've heard about all the different potential tools that we have, AI as well as other potential tools. All of these things only matter if they help people. And we have to be on this journey about how we reach individuals across the world. So I'll close by saying one last thing, in case I didn't make this point. For information drives health outcomes. How we deliver information, where we deliver information, who we use to deliver the information, that's going to matter. And it's time that we start to evolve our healthcare ecosystem to be where patients really are. Thank you.
Okay, let's go to our first salons. Remember, the talks you heard in this room are just the beginning. The speakers are eager to meet you. They know a lot and could tell you a lot more than they were able to fit in their brief remarks here. So please exit the large hall and follow the signs down to the other end of the hotel. And the salons where the people you want to visit with will be marked by their pictures. You are free and welcome to pick up some food, drift in and out of the salons as you wish. This time really is for you to continue the conversations and get answers to questions I know you have. Thank you, and we'll see you back here in 35 minutes. Let's call that 11:40 Eastern. Thank you.
Quality Talks is brought to you by several generous organizations. NCQA thanks Platinum sponsor Merck for an independent educational grant to support this event.
And welcome back to our Quality Talks 2023 live stream show. I'm Dr. Nick. Inspiring, thought-provoking words so far from Dr. Choucair, Dr. Saria, and Dr. Graham. We have 7 more of these brief yet powerful talks coming your way today. Here at the set, in between blocks of speakers, we bring you one-on-one interviews with some of the speakers, and you'll also hear from our NCQA scientists and the leadership, giving you background to these amazing projects and products that they offer. My next guest is one of those leaders here at NCQA. Frank Micciche is the Vice President for Public Policy and External Relations at NCQA. We're glad to have him here to give us a bird's eye view of how NCQA has grown and developed in the past year. Frank, welcome to the show.
Thank you, Dr. Nick. Great to be here.
So if you would, give us an overview of NCQA. What's the elevator pitch?
The elevator pitch is, well, we set standards based on the most up-to-date scientific evidence as to better. We measure folks, organizations, as well as individual clinicians against those standards. We, very importantly, we share the results of that measurement with the world in various forms. And then there's a constant, continuous quality improvement element to it where we are ratcheting up, we are updating standards, we are rewarding those who are improving year to year. So it's a wonderful feedback loop that, if I can jump ahead, is being enabled at a whole different level with some of the work we're doing around digital health quality, which I'd love to talk about.
So before we get to that,
Yes.
let's just talk a little bit about the growth, because you've had a bit,
Yes,
right?
yes. So in pretty much every way that you can measure growth, we've had it. We are, I think, up around 400 employees now. Peggy started this company 33 years ago now, and with just 2. And there was a period where, they were struggling to carve out the existence of quality measurement in healthcare because it really didn't exist prior to her stepping into that void. So we've gone from that, and I've been here 9 years now, and we've grown just in terms of staff, but also in terms of the programs that we've developed, in terms of the folks who are able to leverage our programs in order to improve quality across a much broader spectrum of the healthcare system. So it's really exciting. And as I say, the digital piece is only going to accelerate that growth.
So a couple of the key elements that are being focused on in this year's Quality Talks is health equity and digitalization. You mentioned digitalization. Let's focus on that.
Sure.
Tell us a little bit about what you're doing and what the program's up to now.
Well, it's very exciting. So we're taking all of our programs, but the core, the quality measures that are at the core of many of our programs, and we're making them digital. What that means is folks will be able to report to us, and we will be able to move data in a much more seamless fashion that reduces burden for everyone involved in the system. One of the things we hear, and one of the things Peggy addressed in her remarks, is just how burdensome measurement of quality can be. Everyone agrees we want the highest quality care. What's the cost of measuring it, and then once you've measured it, driving improvement in that area? So we believe that the walls that are coming down now around the sharing of healthcare data, a lot of that as a result of work in Congress and in the administration, with those walls down, with a much more seamless flow of data, with the introduction of the Fire API app, which is sort of the spark, if you'll excuse the pun, to all of this digital work. With all of those factors coming together and the resources and brain space that we're dedicating to digital quality measurement, we think we're on the cusp of a huge breakthrough in a number of areas.
So let's be clear. I mean, most of my colleagues would say, well, we want quality. We're really interested in it, but it's a real challenge to gather. It sounds like you're starting to address some of that with the digitalization.
Yeah, exactly. And I think we have to be careful about what we promise. This will be a gradual process. It's all, well, I shouldn't say it's all forward. It will be also 2 steps forward, 1 step back occasionally. There will be a need for investment. There will be a need for the system to get its arms and its minds around what is involved with digital quality measurement. So there's always that upfront cost. Once having expended that, and that's what we're going through. I mean, we are in the middle of, again, whether it's resources or mind space or work we might be doing on other products, we are dedicating all of that, much of our energy to this digital piece, equity being another priority that I'd love to talk about as well.
Well, no, I wanted to get to that. And in part, one of the things that I think many people will say is, okay, you're digitizing, but that increases the inequity because the folks that were already underserved are underserved by technology. How are you approaching the equity piece of this?
Well, so the good news is, as far as first of all, we're very attuned to that. And I can say the administration, when we talk to CMS primarily about our digital work, but really about anything, the first question they ask is, what's the impact on equity? Meaning not just is this advancing equity, but is there anything in here that unintentionally enhances the inequities in the system? So they're very attuned. We're very attuned. The good news is that for the most part, the type of advancements we're talking about, the technology involved, is not something that the individual person would need to have access to. They will feel the benefits of our being able to transmit data much more fluidly, much more seamlessly, but it won't require that they have even basic technology necessarily. Now, those that do, and however we want to address that gap in technology, they could benefit from it as well, but they don't need it in order to benefit from our early steps.
Fantastic. Frank, sounds like an exciting time. Lots of great focus points. Thanks for joining me on the show this morning.
My pleasure. Thank you.
Folks, our Quality Talk speakers come from all over healthcare and from all over the world. Different training and experiences. And they come to us with one goal, year after year. They're here to inspire. So what's inspired you today so far? What's the best idea you've heard? What's the most surprising? If you've got something to say, type it, post it for us and for everyone to see. Here's a question for you to ponder. If you could suddenly solve a specific gap in health equity tomorrow, what would you want it to be? Tell us what you think. Find us at NCQA on both LinkedIn and Twitter. Use the event hashtag QualityTalks2023. Now, welcome to Arjun Sanyal. He's the Director of Project Management at NCQA. Arjun, welcome to the show.
Thank you for having me.
So tell us what NCQA Digital Content Services is.
Yeah, I'd love to. So NCQA Digital Content Services is NCQA's new product that's been in a pilot phase currently and moving to an early adopter phase. And what it is 2 components. And we've talked about the digitization of HEDIS, which is ongoing. Firstly, that there's 14 what we call the value-based care starter pack. So these are the new digital, very configurable HEDIS measures. And then a software tool, a cloud-based software tool that clients can install on their own clouds to actually run and execute these new digital HEDIS measures.
And I was just talking to Frank earlier, and he talked a little bit about the digitalization. One of the things that he was teasing a little bit, sounds like this is directly in your zone. This is the automation, let's call it, for these measures so that we can capture them with, I'm going to say 0 effort. That might tweak you a little bit.
There's still a little bit of effort too. But, as Peggy was talking about this morning, as the digitization of quality is ongoing, right? And one part of that is the measures. And these measures, I have to say, are not, they're moving beyond the standard measures of reporting, looking retrospectively at the data. They're highly, highly configurable, particularly for quality improvement use cases. And then in the future, these measures will be used for reporting, for digital HEDIS reporting. So there is effort, right? This will be a little bit new to everyone, but measures are not the only thing that we need. We also need software tools, that capability to run and execute these measures. And so we're very excited about this product. We had a pilot program that ran the past year. It was there were 6 participants, and now, if I can make a little bit of a pitch here, we're accepting applications for early adopters for that next phase, and then moving into the future, all of HEDIS will be digitized, and then we'll have a general availability release of this software platform.
So I got to say, that sounds like a lot of activity.
It is.
Let's narrow it down a little bit.
Sure.
So what are your priorities? What are you starting with?
Yeah, we're starting with the quality improvement use cases. And so that these measures can be used to look prospectively for things like care gaps. And when I say they're highly configurable, there's already some configurability in HEDIS measures, but this takes it to the next level. So you can change things like the measurement period to look into the future. You can remove things like exclusions. And then remove things like continuous enrollment. So you can start using, we know that HEDIS measures are not just used for reporting, they're used for all these types of use cases. So we're really putting that into the fore.
So that's fantastic. I think, I'm going to ask you because I heard it from Frank. Yeah. Is there a spark of fire here?
Oh, absolutely. So, as you and people watching the live stream might know, the future of digital measurement is fundamentally based around the FHIR data models. So these are, to use a technical term, these are FHIR CQL measures, just like CMS has been promoting. So, one aspect of this is to get the data in FHIR because that's what these measures, all the future measures, naturally run on.
Fantastic. So, a little bit of time left. Yeah. Tell us what you can about the Data Quality Coalition. It sounds like this is part of the overall project, but you're looking for folks to participate. Is that right?
Yeah, absolutely. I mean, it's the other side of the coin, right? So now, because of mandates and regulations, there are these pools of FHIR data, both payer data and clinical data. And there hasn't been as much use as we'd like to have seen. And so we think one of the reasons why is there isn't really a standardized framework around the data quality of FHIR data, in particular bulk FHIR data. And so, we want to start filling that gap, and we want to work with partners who are like-minded and want to start creating that framework, and then in the future having tooling. So we would love to have participants come and talk to us. Actually, it's dataquality@ncqa.org. You can send us an email and start to get involved and participate.
So if you think about those individual participants, give us an example of the kind of people you're looking for.
Yeah, I think it's pretty broad right now, but we'd be looking at delivery systems, we'd be looking at payers, and even some vendors as well who are interested in the space.
Fantastic. Arjun, thanks for joining me today.
Thank you. It's my pleasure.
There's always a way. Indeed, a better way to improve healthcare efficiency. And Jen Goldsack wants to find them all. Her campaign for digital innovation is incredibly convincing. She's a former Olympian, a tech-enabled healthcare developer. That's quite the combination. Find out more about what makes Jen Goldsack tick. Enjoy this teaser from episode 101 of the Inside Healthcare podcast.
There should not be a single tool, paper, carrier pigeon, or digital, that if we can't see a way that it improves the way we care for all people, that it's a non-starter. We can think about the use of remote patient monitoring. We can think about the use of digital therapeutics. We can think about the use of telehealth and virtual first care, all of which can be very successfully used in different circumstances to improve the way that we care for people.
Check out our Inside Healthcare podcast, available at blog.ncqa.org or from any Apple or Google streaming service. So, I'm excited to invite Dr. Nzinga Harrison. She's the co-founder and chief medical officer of Eleanor Health, a tech-enabled population-based provider that focuses on substance use disorder and provides behavioral and physical care. Eleanor Health is dedicated to treating the whole person. Dr. Harrison is board certified in both adult general psychiatry and addiction medicine. Perhaps most important, Dr. Harrison believes that there is a healthcare system that must have the responsibility to use trauma-informed interventions to address the harms of racism and marginalization faced by many communities in this country. Nzinga Harrison, welcome to the Quality Shorts Toe.
Thank you so much for having me.
So we're talking about racism as an addiction. How do you classify racism as an addiction?
Well, if we take the concept of addiction as a behavior that we continue to engage in despite negative consequences, then racism can fit the definition. We know the negative consequences of racism, and yet as a country, we continue to grapple with the systems that we've built, the individual interactions that we have that make racism a part of our daily lives.
So as I think about this, I'm struck by the fact that it's ever present, but we don't always pay attention. Mm-hmm. Is that what's part of what's going on here? We're just sort of, it's almost part of the background noise, let's say?
I think that's exactly right. So, you know, I'm a psychiatrist, and so we say, lay on my couch and tell me about your childhood. And it's because the things we've experienced in the past, whether we know it or not, are affecting us today. And so it's exactly what you're saying here. Racism is operating sometimes in the background, sometimes in the foreground. Whether it's implicit or explicit, it's affecting the way we're interacting with each other and the impact that we have on each other.
And let's be clear, I don't think I've ever heard racism referenced as an addiction. Mm-hmm. And I got to say, mentally, I'm struggling with that because I don't feel like I'm addicted to it, but I feel like you're going to say we are, right? Is that true?
Yeah, it's true. We all are. And it's because it's built into the very fabric of the systems we interact with. It's built into the beliefs that we were raised with. And so often, you know, with addiction, we don't want it. We don't choose it, but some part of it is compulsory. Some part of it is operating beneath the conscious surface. And what do we say is the first step? Recognizing we have a problem. Right. And so
I am an alcoholic, right?
Correct, right? Or I have alcoholism, but yes, exactly. And so the same way I wouldn't want someone to feel like they had to take on, I am a racist, we can absolutely say, I have participated in racist structures. I have perpetuated, whether intentionally or not, racist things. And so once we can raise our hands and say we have a problem, then we give ourselves the opportunity to make a difference.
So I think the good news here is that recognizing it, now giving it I want to say a diagnosis, but a specific area as an addiction, that means there's a treatment approach.
Totally.
Tell us briefly how that works.
Totally. And so it's really cognitive. It's our thoughts, behaviors, the way we act, feelings, the way we think. And the first is raising awareness. So we raise awareness of the things we are doing, the things that systems are doing that we want to be different. We collect data on the impact that's negative that those are having. And we set a goal. And we set about doing things differently to move that metric of negative impact.
So in the brief moments we have, you know, as health equity gap widens, the behavioral health issues for the disadvantaged increase.
That's right.
Well, how do you react to that?
It makes sense, right? And so as human beings, the way we feel, the way we believe, the thoughts that we have drive our behaviors. And we think about Maslow's hierarchy, the first level of things all of us need: connection, companionship, nurture, stability. The more we take those away, the more we are at risk for acting out on negative feelings, negative thoughts, etc. So the more we can advantage people, the less we're operating in our animal brains, the more we can choose to be different with each other.
I think overall good news.
Absolutely.
Dr. Nzinga Harrison, thank you for joining me.
Thank you so much for having me.
Quality Talks began as part of NCQA's 25th anniversary celebrations and was so successful that we made it an annual event. We've been bringing speakers and healthcare quality leaders together to continue the discussion since 2015. Let's take a look back.
This telehealth movement is now mainstream. The tools are, as I mentioned, across the board. They are complex and they include a great variety of things that will make a significant difference to human health. We now need to make sure that we do not get caught up with innovation for innovation's sake. Innovation must always meet the criteria of delivering value. And that is the thing that we need you to be thinking about, how to apply this new armamentarium in an intelligent way that leads to better quality, better cost effectiveness, and of course, greater satisfaction with people with their care.
It's logical and it's ethical in healthcare. Transparency is logical because patients need information in order to be engaged in our care. And it's ethical because information essential to patients must be disclosed, and patients must be well informed in order to make decisions. And when it comes to our health, we're forced to make decisions.
How different would African American health be in this country if they were seen by doctors who understood the Black experience? How different would the health of immigrants be in this country if they were seen by nurses and doctors who understood the immigrant experience? We cannot do away without caring about the world around us if we want to produce quality care. It is on us, every single one of us. We need to make sure that we move our focus, not just from healthcare, but also to health.
Hi, everyone. We have a special treat for you now. We're so happy to see Dr. Pippa Shulman in person. We know you couldn't make it last year, so we're glad to have you presenting on the stage this year. And alongside Pippa is NCQA's own Dr. Caroline Blaum. She's a senior research scientist in performance management. Welcome, Dr. Shulman and Dr. Blaum.
Thank you so much. Glad to be here.
Yes, thank you. Glad to be here.
A bit about our Quality Talks guest. Dr. Shulman is Chief Medical Officer of Medically Home, the world's first virtual hospital medical home, and it's a tech-enabled services company that provides all the capabilities to safely shift medical care from hospitals to the patient's homes. As Dr. Shulman, she's a board-certified family medicine, preventative medicine, hospice, and palliative medicine physician. In January 2023, Dr. Shulman and her company were described in a New York Times article titled, "Your next hospital bed might be at home." As Dr. Shulman says in the article, when hospitals build a new building, they don't do it themselves. So, we're going to have a one-on-one interview with you, Dr. Blaum, later, but we're going to include you as part of this. We've got you as on your own in the live stream. But to start off, Dr. Shulman, if your viewers haven't already done so, I'd ask you to go find the New York Times article from January 2023. It's titled, "Your Next Hospital Bed Might Be at Home." Congratulations again on appearing in this article and getting the word out. Tell us some of the key takeaways.
Thanks so much for asking. The article, I think, painted a really terrific and comprehensive picture of both the opportunities of hospital at home in terms of patient satisfaction, terrific clinical outcomes and quality of care, but also the complexity that exists when you're trying to set up a safe and effective model of care for patients who are sick enough to be in a hospital.
So tell us where you think this hospital at home movement is going. I mean, I think I could talk to 100 people and all 100 would say, I don't want to end up in a hospital, right? So this is, I think everybody's interested in this, right?
Everybody is interested, and 260 plus health systems across the country have already either begun building or are seeing patients in these programs. The key here is we have to move beyond pilots and make these scaled programs and departments within our health system. And that requires regulation change, reimbursement change, and most importantly, and what I'm going to talk today about, culture change.
So I'm sure everybody's suffered from pilotitis, so not surprised to hear you talk about that. Dr. Blaum, let's talk about health equity. How does this hospital-at-home care help to fill the gaps and create a better access for these patients from an equity standpoint?
Yeah, in my view, and I'm not the only one that thinks this, there's tremendous potential for it to improve equity, and to improve equity in all the places where it needs to, in our cities. You know, in the underserved neighborhoods of our cities, in the rural areas, it has a lot of potential. I don't know if it's completely realized the potential. We do have some evidence in New York City from the experience of Mount Sinai that people who live in disadvantaged areas and vulnerable populations, in fact, do very well with the hospital-at-home model. But that's preliminary evidence. There are many reasons it should, right? Because people can be at home, they can have better access, they can be around people who understand them, they have their family support. So there are many reasons why you would think it would improve access and equity for people. There are some worries, though. We have some worries because, as Dr. Shulman pointed out, and you pointed out, it's very technology enabled. And in some of our areas where there are vulnerable populations, particularly in the rural areas, maybe Native American lands, and even in the urban centers, they don't have great access to broadband and things like that. And we really do rely on, and Dr. Shulman knows better than me, but we do rely on the technology and the ability to get the services that we need there in a very timely fashion. So that's the one worry that we have, and we certainly worry, about housing and some of the social needs that disadvantage that vulnerable populations experience. But nonetheless, I still think the promise is there. And again, getting out of pilotitis and changing the culture and sort of figuring out how to really do this, especially for the people that need it the most, is going to be something that we hope happens in the future.
Yeah, so at least 20 million Americans are without access to technology, internet access. A lot of people talk about Maslow's hierarchy. I keep waiting to see the additions of those two elements. Do you think that's perhaps part of the answer?
I don't know about Maslow's hierarchy. You got me there. But I think part of the answer is going to be in equitable distribution of technology. And I think we are making progress, but there's still progress to be made. And even if we have the broadband available and all kinds of wiring and this and that available, people have to be able to afford it. It's a public utility, really. It's becoming a public utility. So technology-enabled healthcare is not. It's here. And it helps access. It has tremendous potential, and we just have to keep pushing.
So as you think about the hospital at home, this is, it's not all or nothing, right? We can get there in incremental steps.
Exactly. And we really think about the decentralization of acute care that might be urgent or emergency department care, hospital care, post-acute or SNF care, just relocated outside of facility buildings into the home. And I love what Dr. Blaum said, because I think it's so important that we do not ask patients, we do not require people to have all sorts of resources and materials to make this happen. We need to make sure that our systems are set up so that the barrier to entry is very, very low.
Yeah. So I think exciting. I mean, I got to be honest, I'm a patient at some point, even if I'm not right now. I'm excited about this. I know I don't want to go in hospitals. Sorry, CEOs from hospitals. That's just the reality.
They know it.
Great news, great opportunity, but, incremental steps to get there. Dr. Blaum, Dr. Shulman, thank you for joining me.
Thank you so much.
Thank you so much.
If you like the interviews you're hearing today and you want to hear more, never fear. NCQA's Inside Healthcare podcast features a number of in-depth interviews with many of our Quality Talks speakers from today. Every other Wednesday, host David Smolar brings you insightful conversations with clinicians, technologists, and healthcare workers, all dedicated to making healthcare safe and accessible to all. Here's a taste from years past.
Everyone, welcome to another edition of Inside Healthcare, and this podcast just keeps getting better, if I do say so myself, every day, and that's because the quality of our guest.
By the way, we're happy to announce that Inside Healthcare is a gold winner for the 2023 Hermes Award. The Hermes Award is an international competition that recognizes outstanding work for creative professionals involved in the concept, writing, and design of traditional emerging media. So check out Inside Healthcare anytime at the blog.ncqa.org. So I'm delighted to welcome Dr. Rachel Harrington. She's a senior applied research scientist for NCQA. In her work, she develops equity policies that seek to identify historic gaps in US healthcare. And now she's here to explore a milestone in NCQA history and the effort to resolve gaps in healthcare equity. Dr. Harrington, welcome to the show.
Hi, Dr. Nick. Great to be here.
So the Race and Ethnicity Stratification Data and Learning Network, before our viewers' website, tell us about the healthcare data stratification.
Yeah, so we began this effort understanding that what's measured matters, and that to act on the inequities and disparities in healthcare quality, we had to be able to see where they existed. But to see where they exist, we have to know the quality of that data. We have to know we can trust it and that our partners can trust it when they're making decisions. So we brought together a learning network of 14 organizations across the country to share their quantitative data and also their insights, their processes, their best practices to help us understand how organizations specifically were grappling with race and ethnicity data and using that for quality improvement.
So importantly, we've got to maintain the trust in the data because I think that's been lacking in part of the past elements of this, right?
Exactly. It's been on both fronts. We know that individuals, when asked to share this data, have a mistrust with the healthcare system and that we need to earn that back. Why are we asking for race and ethnicity? How is that data being used? But also, our internal decision makers need to know they can trust that information when they're making decisions about which communities they need to put resources into and build connections with. And so that's why we wanted to make sure that we had this learning network.
Okay, so let's have a look at the website.
So what you're seeing here is the landing page of the Stratification Data Learning Network. We tried to make it as interactive as possible. When you go down the page, you learn about the goals of the network, what we were trying to achieve, how we were trying to achieve it. Then, when you navigate up to the top of the screen, you can see options to see our best practices, who our participants were, and a dashboard link up at the top of the screen. We also have a complete report. If you want to get into the nitty-gritty about our methods and our analyses, you can download that for more information. But we recommend folks go up to the top right where we see the dashboard button. Click on that. You'll be able to interact with the data and really go through it and learn about what we saw. Where were the gaps? How complete was race ethnicity data? Where was it coming from? How did that vary by product line, by region, by different quality targets? Really to grapple with some of those questions to make sure we're making decisions on the best foundation possible.
So we've got a decent look at the dashboard. Mm-hmm. Tell us why this stratification matters.
Yeah, so we know, it's not a surprise, the evidence has been out there for a long time, that there are deep disparities in our healthcare system and in the outcomes experienced by different communities. And for us, it's important when we think of our HEDIS quality measures, this foundation, this bedrock of quality, we need to know, is everybody really achieving the same high quality care? And if they're not, where do we need to improve? And if they are, if organizations are doing a good job of closing those gaps, we need to be able to learn from them. And so the Learning Network helps us begin to grapple with that, helps us look at those stratified quality measures, colorectal cancer screening, blood pressure, HbA1c, how your diabetes is being managed, and understand which groups could do better and how we can help support them in that.
Sounds like that's easy to do.
I don't know if I'd say easy, but we're in a moment right now where the healthcare industry is really working with so much momentum. So many groups are coming together, communities, hospital systems, payers. And so we really want to build on that momentum to address some of these issues because, frankly, we can't let it go as it's been.
So that dashboard, how do you decide where to focus, where to stratify?
Yeah, so the dashboard is focusing on 5 quality measures. They were the first 5 measures that we stratified in HEDIS. So they're conditions that we know face inequities in our society: blood pressure, cancer screening, diabetes. And we selected those measures coming out of a public comment period where we allowed members of the public to help inform us what would be important for us to focus on. We've since expanded the number of measures with the stratification. The Learning Network has 5, but in HEDIS, across our quality measures, we're up to 13 now and continuing to expand them this coming year, because we know there are so many areas where we need this transparency and we need to be able to act.
So in the remaining few seconds, tell us what the response has been.
It's been fantastic. I think, in particular, the fact that we were able to pair best practices and insights with data. You can see the numbers alongside the strategies that organizations are using to achieve those metrics was really helpful and helps organizations find what's useful for them that they can bring in-house to make change.
Dr. Harrington, thanks for joining me.
Great. Thank you so much.
Thanks again to Dr. Rachel Harrington. Again, to access the brand new race and ethnicity stratification data learning network, as well as the dashboard, go to https://res.ncqa.org. Quality Talks represents the best and brightest in healthcare quality. These are just quick, savory bites of knowledge for you to consider and explore. For more in-depth exploration of all things quality, register today for our Health Innovation Summit. This 3-day conference brings together thought leaders, trainers, and technologists from throughout the healthcare ecosystem. Here's a taste. Go to ncqasummit.com right now to register and find out all about it. So I'm happy to welcome one of our frequent guests on this Quality Talks live stream, Jon Zimmerman. Jon is the CEO responsible for setting the strategic direction for Holon and its CollaboraNet platform. With more than 30 years of experience, Jon has a track record for helping healthcare organizations accelerate their transition to value-based care. Jon, welcome to Quality Talks.
Thank you so much, Dr. Nick. It's a pleasure to be here with you today.
What is Holon, and how does it relate to NCQA's work of improving healthcare quality?
Well, let's talk about Holon, what it is first. We're a new type of information exchange that learns, understands, and empathizes with end users to really understand what they're trying to do to help them do their best work without having to do the extra work of chasing information. We also track, manage, and deliver the value and measure the value that they get and the value that the sponsor, the payer, gets from their actions as well. So how does that relate to what NCQA does? Well, first of all, NCQA does a marvelous job of defining and understanding what quality should look like and how it can be detected and how it can be missed. So the work is really important to establish that foundation. We know that quality is a very interdependent, multi-stakeholder quest that is very information dependent. So what Holon does is working with health plans and ACOs and others, find that information about that patient right there in the moment, in that encounter, and bring it to the provider exactly the way they want to see it and want to use it, irrespective of whatever system or EMR they're using. So we're a new utility to help them make that transition while using the existing tools that they already have.
So WD-40 for data, bringing it all together for the users, fantastic opportunities. I can't have you here without asking you, are you incorporating any of the latest buzz of artificial intelligence, machine learning into these capabilities?
We are in a couple of ways, and we're also leveraging those of others. So let's talk about that. We use artificial intelligence and machine learning to create that context for the user so we know what to go look for from whatever source. So we use advanced technologies to really understand who is looking at what patient for what encounter at that moment, go and get it. Now, that information that is available oftentimes is delivered by or created through algorithms. So they're using, other companies are using AI and ML to actually make the information that they need. Super important, okay? But if it's not in the workflow, it's not going to be used. It's just artificial. So what we do is we turn it into assistive intelligence. So it's intelligence, but when it's in the workflow, it transitions from artificial to assistive.
Fantastic. So in the remaining seconds that we've got, tell us a little bit about where you position yourself and the company and the data from a burnout perspective. Huge issue, huge challenge, and a lot of it's down to data and the provision of data, right?
Well, what makes burnout? What really makes burnout is too much work to do with not enough resources to do it. So what we do is we eliminate the unnecessary work by taking the work of searching and missing information and just bring it to them in their workflow. It's assistive.
Fantastic. Jon, thanks for joining me today.
Thank you for having me, Dr. Nick.
If you're on social media, let your followers know what you're learning today. Just go to LinkedIn or Twitter, find our account at NCQA, and post your thoughts on today's speakers. Here's another question for you to think about. What non-health technological device do you know of that could be repurposed for remote care? Tell us what you think. Here's how to do it. Type your message and include the hashtag QualityTalks2023 at the end of your post. And remember, follow NCQA on LinkedIn or Twitter. Now I'm excited to welcome Dr. Liz Kuo. She is the Chief Medical Officer for Everly Health. She's an expert in developing and implementing digitalization to improve diagnostic-driven healthcare. This includes using new technology and artificial intelligence to help make care more efficient and reliable. Dr. Kuo is a board-certified, actively practicing in preventative care and occupational medicine. She did her graduate work at Harvard. She teaches there on occasion, and she's also Harvard's entrepreneur in residence. Dr. Kuo is dedicated to using all available technologies, old or new, to place the patient, not the clinician, at the center of care. Dr. Kuo, welcome to Quality Talks.
Thank you. Thanks for having me.
So, Everly Health's website, you use this graphic to explain modern diagnostic-driven care. Can you help us explore these ideas?
Absolutely. So our goal is to create affordable, accessible care from home collection. So being able to help any patient who has a question about certain things, let's say diabetes or food allergies, food sensitivities, collected at the home. What we really love, though, is the idea of not only self-collection, where you don't necessarily have to wait on somebody else, but you can click on a button on a website, get the test, collect it yourself, whether it's urine or a few blood samples, and then send it back in the mail and get the results within a couple of days. We love this idea of the triangle, as you mentioned, because the triangle is focused on, number one, making it easy, accessible, and also focused on this idea of helping patients really feel empowered to test and not be scared about the test results. The second is the idea of the enterprise model. So we do work with a lot of payers to close care gaps. We work with NCQA to make sure that there are HEDIS and STARS measures where we support the whole payer side, the employers, and those that are able to cover for things. So we have a direct-to-consumer model, but we also have an enterprise model where we're working with payers to deliver care. It's a nice flywheel because patients see us on TikTok and Instagram and Facebook, but they also then get a letter from their payer, from their employer, and saying, hey, this is an annual wellness test. We're really excited to have you test and check your heart health, check other things, and they're less scared when they see that. And then the last thing, of course, is this diagnostic, modern-driven care. So we're really pushing the envelope on innovating. COVID really helped support the pandemic.
It certainly did.
Yes, within the home collection virtual care model. So we're doing that right now, building out this great ecosystem.
It sounds like a lot of this sort of is helping push us to the home healthcare model and, you know, allowing or enabling everybody to participate, not just those that have accessible resources, but even opening it up further than that.
Yes, our goal is really to try to help people understand that they can do things on their own. We've even, funny enough, had people say that they do wine and cheese parties in their own homes with a few tests, and they enjoy it because they feel very excited about learning more about their own health.
I'm sorry, you got me laughing there because I'm thinking about the old Tupperware parties,
Yes.
and this is the new innovation of Tupperware is Everly Health parties. So
Yes.
that's good to know. So one of the highlights and specifics in this conference is obviously health equity. I think we saw a spotlight shone on this with the pandemic, sort of opened many people's eyes,
Yes.
including my own. Let's be frank. How are you addressing that? How are you approaching the health equity aspect?
Absolutely. So there's a lot of people that are in their homes immobile or unable to get out. And so what we try to do is make it not only accessible, but affordable. So our tests start from anywhere from $40 to $200. And the idea is people can pay with their FSA, so flex spending, but there are also payers who can reimburse for it. Our goal is to not only make it easy, but as you were mentioning, hit rural areas. A lot of Americans don't have PCPs. There's a shortage of doctors. Sometimes you wait 5 months for a gastroenterologist, and you may not know what's happening to you. So being able to test at home is key.
Right.
And then also, virtual care has become sort of table stakes. It's bread and butter right now. So being able to have lab tests support the diagnosis is really key. Lab tests are helping about 70% of all diagnosis. So if you can imagine improving the way that we test at home with self-collection, being able to get it and done without necessarily a healthcare provider, really can improve not only diagnosis and screening, which NCQA is so focused on, but also the ability to get people aware. One example is kidney test. So we can do something called EGFR, which is kidney function. 90% of Americans that have chronic kidney disease don't know that they do. And it's about 15% of the population. So being able to test at home just with a few drops of blood and some urine can really change people's awareness.
Yeah, so that a lot of these increasing numbers of biomarkers gives us tremendous opportunity for this, so that's exciting. We got a little bit of time left. I know you're an entrepreneur in residence. There's like a billion people out there with lots of great ideas.
Yes.
How do they approach it? What is your advice to them to get this out of the box and actually out into the community?
Absolutely. I think people need to believe in themselves, and the goal is to actually work on understanding the infrastructure. NCQA is one, but also understanding how things get reimbursed. Do you go first direct consumer, and then you go back to getting payers or reimbursed? It's also understanding commercial lines of business. So what is Medicaid reimbursed for? How do they think about it? What is Medicare? And what is the commercial line? So Americans usually are employer-based healthcare. So it's understanding some of that is key. I also encourage a lot of entrepreneurs to ask experts, and I'm very happy to share my email, and people reach out to me on LinkedIn all the time to ask about, if I'm interested in this, how do I manage my technology, but my innovation within the regulatory ecosystem that they work through, and making sure that they understand all of it. And then lastly, I'm a physician by training, but I also think it's really the patient. So what is the pain point that the patient is experiencing is key. And whether or not you have a technology that could support the pain point, you actually have to figure out, like, what are you trying to solve for?
So I'm just going to highlight that. You heard it. Dr. Liz Kuo said she's happy to take open invitations and she takes email. I mean, that's a rare entity, and I think it's important, and I think it's very generous. Dr. Liz Kuo, thanks for joining me today.
Thank you. Appreciate it.
We have an entrepreneur in the house today. Dr. Liz Kuo is at Quality Talks this year. She's talking about the idea of healthcare at home. But more than that, if you had an idea or a gadget that can improve health for everyone, she can get you on your feet. Learn more about tech in healthcare in episode 102 of NCQA podcast Inside Healthcare.
Being able to, especially with your smartphone, at the touch of a button, order everything from drugs to certain devices to tracking and sending information out to your caregivers, and being able to talk to a robot, a chatbot, and really feel like you're having a detailed, helpful, personalized conversation. I talk about the 4 Ps usually. It's if you can leverage data to make it predictive, preventative, prescriptive, and ultimately personalized.
Check out our Inside Healthcare podcast, available at our blog.ncqa.org or from any Apple or Google streaming service. So I'm lucky to have Dr. Suchi Saria. She is the founder and CEO of Bayesian Health. She stands firmly at the crossroads of artificial intelligence and modern medicine. Her research has pioneered development of next-generation diagnostic and treatment planning tools that use statistical learning methods to individualize care. Dr. Saria is also the director of Machine Learning, Artificial Intelligence and Healthcare Lab at Johns Hopkins University. Dr. Saria, welcome to Quality Talks.
Thank you for having me.
So first, I think it's important to define some terms briefly. We hear a lot about ChatGPT. I know you've talked about this. If you can, help people understand what does ChatGPT, what is AI, explain that as briefly as you can, and I know that's a tall order.
Yeah, so AI is just a field where scientists work to design techniques to be able to build machines that are smart, intelligent. And this means, loosely defined as whether it's mimicking human behavior or augmenting to do things that humans can't do. And machine learning and there are a variety of different kinds of techniques, effectively, by which we learn. A lot of this is about learning from data. So as you have vast amounts of data available, how do you design these algorithms to learn by either, using and observing the data directly or interacting with human experts or, learning from experience from interacting with the real world. ChatGPT in particular is an example of a tool that was introduced for conversational bots. So it's effectively a model that is working in the background. What it's doing is taking a huge amount of context to predict, given all the words I know, what is the next word, and what's the next word, and the next word, and next word. And what this really means is pretty cool. You can, ask ChatGPT to write you a poem. You can ask it to write you
You said love letter in your presentation, but go on.
That's right. It's very, very cool. And so what it's really doing is it's studied the internet. And it's studied language, right? It studied things written in English. Studied things written in other languages. And you can treat it, teach it on what good poetry looks like versus bad poetry.
And that comes up, one of the points or things that you mentioned in your talk was human-machine teaming.
Yeah.
Which I think is a great sort of concept. Share a little bit of what you meant by that and how that might work.
Yeah. So there are different types of applications, right? There are applications where the system on its own is doing a closed-loop task. What this means is there's some task we already know we need the system to just do it. It's acting fully autonomously to do it. There are other scenarios, which I think a lot of medicine and healthcare is like that, where there's an element of augmenting experts. So it's basically you're trying to solve a task, but you're doing it together. And it's almost like, imagine in medicine, we're used to this idea of a consult, right? Like you go and you ask these other experts, hey, I have a case, what do you think? Or, you have a case you're trying to solve and a team comes together to do the task. And there are different roles, different people within the team play. So in that sense, machines can now be part of that team.
Right.
And it's actually pretty cool because they can help you in a number of ways. There's all this data that needs to be parsed. Nobody has the time to parse all this data, but if you can parse this data to find what are the most salient bits. It's hard for a clinician to be with a patient 24/7 or with a person 24/7, right? If you can collect all this data, parse it to identify a salient moment for them when their attention is needed, that's very interesting. You can now make it very easy to evaluate. Can you help them in documentation? Making it very easy to code and document what is needed. Close gaps. What needs to be completed? Taking patient priorities into account and prioritizing what would be relevant for this patient, right? So there's such an opportunity for teaming.
So as I think about this, one of the recurring themes I hear repeatedly is a lot of resistance. It's going to replace me, replace jobs. I don't believe that. I think it's more of that teaming approach, which I think is why I anchored on that. Tell us how you see that and how people should think about this in the future.
So, for instance, the work that we're doing with Bayesian Health, a lot of it, the way we've, if you think about it today, physicians are like burnt out. The caseload is increasing. There's way too much data to parse. There's all these clicks they have to do to be able to get to the data in the first place. They have very little time with the patient to do what they need to do. And also there's like the burden of measures and quality, right? all these things they need to do, they need to be compliant with, but there's no help. They don't have any help in the process. And the tooling they currently have is mostly interruptive, disruptive, noise, alarm fatigue. So now imagine if there was an intelligent assistant or an intelligent agent that was reading their data, making it really easy to run in the background, identify ways in which, in the example I gave with sepsis, but you could translate it to all sorts of other problems like readmission, like pressure ulcers.
It essentially captures all of that, automates many of the mundane tasks, and brings us back to the patient. Exciting stuff. Dr. Suchi Saria, thank you for joining me.
Absolutely. Thank you.
Now it's time to return to the stage for the next session of Quality Talks. I'm Dr. Nick. We're here live at the Capitol Hilton in beautiful downtown Washington, D.C. We'll see you right back here on the live stream before 1 p.m. For now, don't go away. This is Quality Talks 2023.
More Quality Talks. Stay with us for our next theme. Health equity looks different from here. Dr. Nzinga Harrison, Dr. Aaron Neinstein, and Dr. Anita Ravi are on deck. Don't go away.
There's more than one way to look at the world. At Bayer, we look through the lens of science and work with the courage to care. We don't just provide food and promote healthcare. We feed and heal, innovate and empathize, use science and add soul. We unite our collective strengths across the country to help communities thrive around the world. And we know there's always more to be done. More questions wanting greater answers. More to invent, to give, to aid, and to heal. We labor with love to develop the most trusted products and sustainable solutions, bringing the full power of our business forward for the holistic needs of people. With science as our foundation and empathy as our compass, we will lead with heart to break through for humanity.
Hello, welcome back. We went into a little overtime there, didn't we, with the salon discussions and the meal. Glad to see it. I know there was a lot of dynamic interaction with the speakers, and so we're glad you're getting a lot out of visiting with them. Our next speaker, when she was in medical school, was in an a cappella group called Arrhythmia. And now you might guess that she went into cardiology, but no, she went into psychiatry, and she works now as an addiction psychiatrist who has developed an intriguing idea about health equity, and it is that racism is an addiction that you can treat similar to how you might treat someone for addiction to drugs or alcohol. Please welcome Nzinga Harrison.
Thank you. I promise not to break out in song. So we know underlying addiction is trauma. And you see what we'll talk about this morning is moving beyond a trauma-informed approach to a racism-informed approach. Racism is trauma. Discrimination is trauma. Marginalization is trauma. Oppression is trauma. If you heard me say those words and you felt a physical reaction in your body, maybe a sense of relief, a sense of validation, I see you, I hear you, I am you. If you heard those words and you felt a little skeptical, like, I'm not sure I believe it, it's okay. I'm not here to convince you this morning. And although I hope to plant a seed for the next 13 minutes and 49 seconds, racism, discrimination, marginalization, oppression is trauma, and we all believe it. So why do we believe it? How do we know that's the case? We know it from the trauma of our own lived experiences with racism. We know it from the vicarious trauma we experience from the racism, discrimination, marginalization, and oppression that our patients have experienced, our colleagues, our friends, and family members. And we know it because our high school teachers taught it to us in math. No? I was like, question mark, question mark, question mark. You're like, my high school math teacher was definitely not talking about racism and trauma. I'll come back to it. I'll come back to it. Racism, discrimination, marginalization, oppression. 5 years ago, I couldn't stand on a stage and say those words all in a row, and people keep listening. Racism, discrimination, marginalization, oppression. Every time I say it, I think lions and tigers and bears, oh my. I'm like, racism, discrimination, it's too many syllables, but whatever. You get it, it's stuck in my brain, so now it's stuck in your brain, right? Before we get to your high school math teacher, let's go through a history lesson. In the 1970s, Vietnam veterans were coming back from war. This is really when the medical establishment and health system started to recognize the impact of trauma on mental and physical health. And it became an area that people were interested in learning more about. Eventually, the diagnosis of PTSD was created. And then into the 90s, it was like, oh, beyond war as a trauma, there are so many different types of traumas that people are experiencing that's affecting mental health and physical health. And it was the 1990s that Anda and Felitti gave us the gift of the ACEs study. Adverse childhood experiences, 17,000 people drawing a direct line from childhood trauma to adult mental and physical health. That really opened the idea like, oh, trauma is not just being shot at, and trauma doesn't only result in flashbacks, the concept of PTSD, but this wider set of physical and mental health conditions. And it was in 2014 that SAMHSA rolled out the first national strategy and framework for a trauma-informed approach. The trauma-informed approach gave us 3 E's, 4 R's, and 5 principles. So this is what we're going to spend the rest of our time on. 3 E's. SAMHSA said a trauma is an event or series of events that is experienced as harmful, that has lasting negative effects on mental, physical, or social well-being, also known as mental well-being. An event or series of events that is experienced as harmful, that has lasting negative effects on mental and social well-being. So let's see, do racism, discrimination, marginalization, and oppression fit the 3 E's? Is racism an event or series of events? Okay. Is discrimination experienced as harmful? Oh, nobody like, oh, you know what I need today? Some discrimination. Do marginalization and oppression have lasting negative effects on mental, physical, and social well-being? Okay. So racism, discrimination, marginalization, oppression meet the definition of the 3 E's. This is how we get back to high school math. Do you remember if A equals B and B equals C? Say it with me. A equals C. I know it. It's like riding a bike. All the time we thought high school math, we were like, this is useless, never gonna use it. Here we are. Here we are. So if trauma equals the 3 E's, and racism, discrimination, marginalization, and oppression equal the 3 E's, then A equals C. Racism, discrimination, marginalization, and oppression equal trauma. So now that we all believe it, what do? SAMHSA gives us the 4 R's. We realize, we recognize, we respond, and we resist re-traumatization. We realize, we recognize, we respond, and we resist re-traumatization. That's the commitment we make when we are building a racism, discrimination, marginalization, oppression-informed system. We realize how widespread the impact of racism is for the 100 teens that reported more than 5,600 instances of racism in only a 2-week period. We recognize for the more than 1/3 of LGBTQ people who have to hide their relationship, what the symptoms of that trauma looks like, of that discrimination. We respond by building systems that have policies, procedures, regulations, and laws that protect the more than 1/3 of Americans with physical disabilities who experience marginalization as part of their everyday existence. And we proactively seek to build systems that avoid re-traumatization for every single one of those communities I just mentioned, as well as all of the communities I haven't mentioned that have been struggling and fighting to survive and thrive under the weight of oppression generation after generation. It's a tall order, and so how do we do it? We know trauma is the 3 E's. We know what we have to do is the 4 R's. How do we do it? Thank you, SAMHSA, for giving us the 5 principles. Okay, now, here's a, secret, which is not a secret. There are actually 6 principles. And 3, 4, 5 is definitely easier, right? But it's 3, 4, 6. It started out as 5 principles, and then SAMHSA came back and added a 6th principle. So we'll go through the original 5 principles, and then I'll do a big reveal on the 6th principle. The first principle of a trauma-informed approach, this morning we're talking about a racism, discrimination, marginalization, oppression-informed approach, is safety. We have to create environments that actually are psychologically and physically safe for the people we are serving. And that environment could be a physical environment, that environment can be cultural environment, whatever. Number 2, trustworthiness and transparency. I think we can all agree that the healthcare system is neither transparent or very trustworthy for many communities. I always cringe a little bit when I would hear, during COVID, they would be like, Black people don't trust the healthcare system. And okay, yes, right, at the top level. But what's probably more accurate is that the healthcare system has not been transparent or trustworthy for Black people. Let's put the onus where the onus is, which is on the system we've created. And so trust and transparency, I didn't mean to get on a little soapbox, so I was like, Number 3, peer support. Are we proactively creating opportunities for people to be with and receive support from people who have a shared lived experience? Number 4, collaboration and mutuality. Y'all already know about collaboration, so I'll spend the time on mutuality, which is leveling the power dynamic. If you are designing for health on behalf of a community, you better have decision-making, power-holding voices on the board, on the executive team, on the leadership team, on the frontline staff. I'm from Georgia. I'm sorry, I'm from Indiana. I live in Georgia. It's compounded, right? Frontline staff. right? I'm not talking about an advisory board. Love them, have no decisional power. Oh, amen, coroner was like, exactly. Right? Collaboration and mutuality. Number 5, empowerment, voice, and choice. So when we're designing systems, we can't design for the individual. We have to design at a community level. We have to design at a population level. And so we have to make sure that even as we're designing at a community level or a population level, that we are building in operations that allow for empowerment of the voice and choice of the individual in real time. Because even though Black people this and LGBTQ people that and immigrants this and Muslims that, right? Like at a community level, yes. At an individual level, you don't know me. You don't know me. You don't know what I need until you hear me, until you see me, until you are with me. Right? And so how are we building systems that empower that individual choice and voice? And then, okay, we're on number 6. Y'all ready for the big reveal? Before we get to the big reveal, I'll give you a little history of how it came to be. March 2020, we all experienced the collective trauma of watching Officer Derek Chauvin murder George Floyd right before our eyes. The country erupted, the world erupted in a collective, sustained trauma response. The CDC partnered with SAMHSA to add the 6th principle, which was historical, cultural, and gender issues. Cultural, historical, and gender issues as the 6th principle. You know what that was? That was the CDC and SAMHSA saying, oh snap, lions and tigers and bears. Oh my. Racism is trauma. Discrimination is trauma. Marginalization is trauma. Oppression is trauma. And so here's a call to action. I'm not gonna stand up here and be like, okay, so now all of y'all go back to your respective workplaces and implement racism, discrimination, marginalization, and oppression-informed care. That would be like unfair, right? It's a big ask. So I firmly believe that before we can walk the walk, we have to talk the talk. All I'm asking is that you tell somebody about the 3 E's, the 4 R's, and the 6 principles of a racism, discrimination, marginalization, and oppression-informed approach. For some, you'll be validating their experiences. For others, you'll be planting a seed. For everyone, you'll be making a difference. Thank you.
Our next speaker had an unlikely on-ramp into the medical profession. Get this, for the last month of med school, he worked at the clinic of Big Sky, Montana. That clinic is next to a ski resort, which means for the last month of school, every day he would spend half the month in clinic and half the month skiing. And that in turn means that he earned his very last credit in medical school on a chairlift. Now, he's quick to point out that ever since then, things have been quite different. And from that unlikely beginning in Big Sky, he's gone on to make big contributions to people who are interested in transforming their analog organizations into companies ready for the digital age. Please welcome Aaron Neinstein.
Thank you so much. It's great to be here. So if you're anything like me, to get to this great event in DC, you pulled out your phone and you checked into your flight on an app. When you arrived at the airport, you pulled out your phone again, you used a rideshare app to get to your hotel. And then when you got to the hotel, you pulled out that phone again, you started binge watching the latest season of Ted Lasso or Succession. And across every phase of our lives as consumers, we are expecting frictionless, on-demand convenience. We want things when we want them, where we want them, how we want them. And we're bringing those same expectations with us into the healthcare arena. So how have we fared over the last decade with technology coming into healthcare? Well, I certainly don't want to go back to paper records, don't get me wrong. I can e-prescribe, I can view lab results and clinic notes from other doctors from around the country. I don't have to decipher handwriting, although I still have no idea what ophthalmologists are writing about, even though it's digital. But if you look at the greatest challenges we face in healthcare in this country, has technology really allowed us to overcome them? We face challenges with cost, with access, with disparities, with poor patient experience, and of course, rising burden and burnout among our doctors and our nurses. Now, lots of investment is going into trying to change this. So we're seeing new models of care built by healthcare systems across the country. We're seeing venture capitalists pour billions of dollars in. We're seeing payers creating new models of care with provider networks, and those networks are getting bigger and bigger. And of course, big tech is even getting involved, most notably with Amazon's purchase of One Medical Group. So we have the opportunity in healthcare to often look at other sectors and other industries to see what they're doing and to take lessons and learn from them. So we could, for example, learn lessons from one of the first early large retailers to sell consumer products through the internet, or one of the first media companies to stream media into people's homes. And you know exactly which two companies I'm talking about, right? So think again. So what was it that separated Amazon from Sears and separated Netflix from Blockbuster? Because while what was visible about what Sears and Blockbuster were putting in front of their customers, what was different was below the surface. So what Netflix and Amazon did is they built technology infrastructures that captured granular data about the end-to-end experience of their customers. They built organizations, teams, cultures around using those data to glean insights and to have those teams iteratively improve their products, their services, their experiences over and over and over again. And that's what they understood. And if you think again about American healthcare over the last decade, we took technology and we put it on top of our existing organizations, and we have not yet done the really hard work of transforming what's below the surface. And that is the challenge and the opportunity of the decade ahead. Now, I grew up in Los Angeles, around the corner from a place called Arts Deli. I used to go there on the weekends for brunch with my grandparents. And like any good LA or New York deli, they have an enormous menu, something for everybody. But now contrast what happens when you take that paper printed analog menu and you ingest it into DoorDash. DoorDash now can tell me with precision when I go back to my hotel room tonight and I've never ordered from a restaurant in this area in DC. They know based on my ordering history and my preferences what menu items might be most interesting to me based on the restaurants in the area that I've never eaten at before. They can look at tens of thousands of restaurants across the country and hundreds of thousands of menu items and answer important questions like pastrami or corned beef. The answer, corned beef. Now, just like DoorDash is not just a food company, as healthcare companies, we also have to be great, not just at delivering healthcare, but at understanding the data that we collect within our organizations and with the provision of care and using it to iteratively improve. Now, you might be sitting there thinking, oh my gosh, Netflix and Amazon were startups at the time. They got to have a fresh start. I work at an organization that's been around for a long time. I work at UCSF. We've been around more than 100 years. There are great examples of companies that have been able to make the transition into digital organizations. Think Target, Walmart, Delta Airlines, Home Depot. So let's talk for a few minutes about what a virtual care future might look like, and then I want to leave you with some practical tips for how to think differently about your organizations. Now, I'm an endocrinologist. I see lots of patients with type 1 diabetes. And in taking care of people with type 1 diabetes, they frequently wear continuous glucose monitors that measure their glucose every few minutes. They wear insulin pumps that deliver preset regimens of insulin under the skin continuously, 24/7. And in the early part of my career, I would sit in the office with people with type 1 diabetes, and we would download tens of pages of data that looked something like this. And we would try to glean patterns from the data, and I would try to use those patterns to make predictions about what their insulin regimen changes would need to be. Now, fast forward into 2017, the first automated insulin delivery system became available. And we would talk in the back office, do people need endocrinologists anymore? Now that we have, these algorithms that are continuously adjusting people's insulin regimens for them, why do you need an endocrinologist? Well, I've been actually completely surprised and delighted by what has happened. It turns out that instead of spending my time trying to be a poor substitute for a computer and looking through these pages and pages of data, I actually talk to my patients. And we get to talk about what are their challenges and their needs in life with type 1 diabetes. And so I think Eric Topol really got it right. He said this in his book, Deep Medicine. We don't need AI to cure cancer. We need AI to help us restore the human connection in medicine, that human connection between the doctor and the patient. Now, as precious as that is, it's also very expensive. And so having a patient, a doctor, a building in the same place in the same time is an unsustainable way to try to deliver care to everyone who needs it across this country. And telemedicine has relieved some of those geographic boundaries and barriers, right? So no longer do you need to be tethered to a place. But at the end of the day, it's still a synchronous unit of time and interaction. And so we have to be shifting more care using technology into new care modalities that leverage artificial intelligence and leverage asynchronous modalities of care. So one example of that, at UCSF, we have one of the largest lung transplant programs in the country, about 500 people who are living all over the Western United States having had a lung transplant. And we used to bring people to San Francisco for pulmonary function tests regularly. We would fly pulmonology doctors to Boise, to Portland, to Reno, to have appointments with patients at satellite locations. What we started doing during the pandemic is we sent people a home spirometer, and they enrolled in a chat program, and so they text with us about their symptoms every week, and the results have been fantastic. We have had great patient satisfaction. People have reduced by about 40% the frequency with which they travel to San Francisco for their care, and our quality results are great. No change in emergency room visits or hospitalizations. In fact, the rates are even a little bit better than they were before. So where we might be headed in the future, of course, is ingesting lots of data like the continuous glucose monitoring, like we see with the home spirometers. We can understand, just like DoorDash, right? What is the personalized, precise treatment that is needed for each person? And then as we deliver that treatment plan, how do we tailor it to individual needs, and how do we adapt education and content to people's individualized needs along the way? Okay, so how do you get there? How do you make yourself a digital organization? Well, the first thing is to look in the mirror and remind yourself that this is not what your organization looks like. We no longer have a calm waters and a predictable destination and a predictable path to get there, and just have to stay pointed at those clear, calm waters. It looks more like this. So we have to create organizations that are capable of sensing the environment, of understanding that that environment is dynamic, is complex, and of putting agility into our organizations to change on the fly. So one way we've tried to do this at UCSF and learning the lessons from Sears versus Amazon is in the past we might have said, let's focus on getting self-scheduling to our patients. And that was looking at what was above the surface, what was visible about self-scheduling and delivering that to our patients. What we've done now is we've said, you know what? We're a complex care organization. People come to us in a time of need when they've been diagnosed with cancer or their kid has been diagnosed with type 1 diabetes, and they're looking for care. And that experience of someone who needs a tertiary quaternary medical center for that acute moment in their life, that's something that's going to be an important part of our experience forever. So it's not just a one-time project where we turn on self-scheduling and go on to the next thing. We built a team around the new patient experience, and they wake up every morning and they look at the data. And so we've put granular data collection into that entire end-to-end experience that our patients are having. And this team wakes up every morning and they try to understand, where are our patients facing friction in that process? What is their experience? How can I iterate that experience to make it better tomorrow than it was yesterday? Now, one thing you realize as you start looking at the end-to-end experience, if you're a healthcare system, is guess what? We don't control the whole thing. When patients come to your portal or your website, they have already been looking on Google. Most healthcare searches start somewhere else. And so as we think about digital experiences and becoming digital organizations, those integrations and weaving together the ecosystem and looking through the lens of the patients we serve become critically important. Another important lesson that becomes apparent, I don't know if anyone's had a similar experience to this. I called in a takeout order to a restaurant a couple of months ago. When I got there, I waited in line for half an hour. Turns out there was one cashier at one register, and there was a line of people who were ordering in the restaurant, people like me who had called in orders, and then just hordes of Uber Eats and DoorDash drivers all crowded around this one register. And the restaurant had not redesigned itself for a world that exists in digital and analog interactions. Our physical footprints are built for analog world. Now, contrast this, this was actually just a few days ago. I went to pick up some pizza, and the restaurant had completely redesigned a drive-through for curbside pickup. Or contrast that to last time you put an order in at Target, right? What did you do? You took out your phone, you placed the order on the app, you drove your car up to the Target parking lot, you open your trunk, they put the bag in, you drive away. And so we have to rethink experiences. Digital is not a separate thing. Digital is something that is woven into the fabric of the experiences that we deliver to those we serve. One other thing about digital is there are many capabilities that are important to becoming a digital organization. Understanding at a granular level who the different patients or customers are that you serve. Using design and human-centered design principles to do user research with an inclusive, broad group of people. Collecting data about who's using your services and how they're using your services, and understanding at a personal level the differences in how they're engaging. Now, think about the challenges we face with health equity and disparities. And those very same principles that can make you great as a digital organization can also be important in advancing affordability and access and individual delivery of care. Because equality, right, giving people the same experience is not the same as equity, which is meeting the understanding and meeting the individual personalized needs of those we serve. So if I leave you with one thing today, it's to remember that if you're a healthcare system and you think that you've solved the patient experience by having a patient portal or having a consumer-facing website, that's just what's visible above the surface. And digital is not that. Becoming a digital organization is about everything below the surface. And so it's about having the expertise in your organization, in design, in data science, in product management. It's about having standard workflows because you have to be able to measure and collect data from standard operational workflows. It's all about the data, how you collect it, how you use it, creating data literacy within your organization. It's about creating cultures like Netflix and Amazon did around continuous improvement and about using those data to iterate over and over again. And it's about thinking not like the restaurant with the one cashier, but like the restaurant who had or Target who have you pull up and do curbside. It's about thinking about the entire ecosystem of care. Healthcare does not exist just within the four walls of our hospital or our clinic or our health system, but you have to view it through the lens of the person you're serving and think about their experience and design for that entire ecosystem that they're a part of. Thank you so much.
Every once in a while, you meet somebody who changes how you think about a topic you've been working on for a while. Speaking for myself, the next speaker has done that with regard to health equity. She has found her calling caring for people who have been incarcerated, who are survivors of abuse, and who have been trafficked. It's hard not to think about health equity differently after you read about that lens that she brings to her work and after you learn what she has done. People she works with have been through terrible things, and yet she is the most optimistic and sunny person you will ever meet. And today, she is here to share something new and different with us. Please welcome Anita Ravi.
Hi, everyone. It's an honor to be here, and it's because what I'm about to do is a big public experiment, and I hope it goes okay because my parents are watching on the live stream. So one of the toughest things, I'm a family medicine doctor, and one of the toughest questions I get asked, and the questions that I dread the most are, what do you do? And I always wonder, like, okay, how can I do justice with explaining the type of care that I do and really make it resonate so that people keep listening? And it's true, a lot of the work that I do, so I run a nonprofit healthcare organization called Purple Health. And what we do is we do free comprehensive healthcare, so that's integrated primary care, mental health care, and care navigation services for survivors of gender-based violence. So our patients have experienced human trafficking or domestic violence, sexual assault, and they may be anywhere in that journey of that experience. So they might be in the midst of it, they might have experienced it years ago, but there's something about their healthcare needs that have kept them from engaging with care that they needed. And that's actually that's the toughest part of explaining things, is explaining the trauma of the healthcare system. And so that's one of the things that I've been like, okay, how can I explain what the patient experience is like for people who've experienced trauma? The other tough part is explaining what I do about it. So I have an awesome team. Today's a clinic day, so I'm gonna say hi to them also. My teammates are Jessica, she's my co-founder, and she's a social worker and mental health care provider. And then my colleague Keisha was my former patient, and she's a survivor leader and care navigator. And we meet and we troubleshoot all the time. Sometimes we spend up to 50 hours figuring out how to get one patient comfortable engaging in care for their first appointment. It takes a lot of work. So I was trying to think, like, how can I summarize what we're doing in a job description? And the term that came to mind is this idea of being a trust engineer. And I think it's right, because I think when you have traumatic systems, you need trust engineering, and you need it in a lot of different ways. So that's what I want to talk about today. And I was trying to think, well, what's the best way to be able to illustrate it? And I know the answer is obvious, but I'll just say it anyway. I figured the easiest way to tell you what it looks like for a patient to go through our healthcare system if they've experienced trauma, and how we can do moves that are engineering trust in their experience, is by using Mario Brothers, the 1985 version. So just want to talk about what that patient experience might be like with the back show of Super Mario Brothers, the 1985 edition. So you can see right away on the first screen, Mario Brothers has metrics. And so I want to pull your attention to a couple of these important metrics. When I see Mario times 3, I think about, okay, I have 3 tries. Sometimes you're lucky. Sometimes you can only engineer 1 shot to be able to engage with someone in care. Sometimes you might get 10. But when a system isn't designed for you, you really rely on someone's resilience in order to survive the system. So let's say you have 3 shots to engage a patient in care. You have a certain amount of time that the system allows for you to do it, and then there's the coins up there, and we'll get to that in just a second. So let's talk about that first try in the patient experience. So we talk about systems design and trust engineering. The very first question or the very first engagement we have with someone is showing people our values and what we value in a system. I think it's really important. If you take one thing away from this, is healthcare is not the only broken system that our patients engage in. They have a history of systems that we're supposed to help and that let them down, whether it's family court, whether it's the education system or other systems that they were supposed to trust and they tried and it didn't work. So we have to think about that. When we think about the ecosystem of our work, we have to think about the other systems that our patients are engaging in. And if you want to keep them engaged, it might be an important question, but we need to think about where to ask it and what happens after someone answers. It sucks because honestly, some of my patients have Medicaid and it'll be turned off when they come off of, when they're released from jail, and then it'll be turned back on. Half the time it's active and they don't even know it, so they're afraid to use the insurance that they have because of what happens after they say no or yes. Sometimes they have to see a financial counselor before they can actually see a mental health specialist or a primary care doc. So something to keep in mind. All right, so let's try again. Let's say that someone feels they're still approaching with a little bit of anxiety. You could go faster, but you get past that front desk interaction. You answered some questions. You helped the system get money. But now you're faced with these quality metrics questions. And a lot of the things that our systems do is we innovate for efficiency, right? We're like, you know what? We could take advantage of the waiting room time and we could just give people an app and have them answer all of these questions that would help us get our metrics and so we could get reimbursed and it'll be good population health. So we might ask people, any recent ER visits? Because we know, okay, every time I hear people, this is a trust engineering tool that you can use. Whenever people give presentations and they justify why their idea should be invested in, I think about the order in which that they talk about their innovation. And people will say it's because it's going to save the system a lot of money and it could improve patient outcomes. The order matters, and that is another thing I think you'll see here. But patients notice that too. And the thing is, we've heavily invested in these overutilizers, the high utilizers of care. They cost the system a lot of money. And we're like, okay, there's other ways that we can get them engaged. They're not using the ER a lot. I work with people who are underutilizers, and I don't know who's innovating for them. They're people who need care. When I talk to them, they don't trust the ER to go in and get the care that they need. And that's a problem. And I say that here because I strongly believe that there are solutions and there are people who are motivated to be able to answer that question as well and do it in the order that matters. So we have that, and then we have the PHQ-9 related questions, the depression screening. It's evidence-based when you say, any thoughts about hurting yourself or anything like that? And then we've engineered even social determinant of health questions, right? But patients kind of give me the backstory on how they answer these, and I'm telling you because you're collecting the data and you're making decisions based on data that you feel is largely accurate. My patients will fill out the PHQ-9 and they'll be like, no, Dr. Ravi, I'm putting 0 for everything. Because the last time I answered honestly, I was put into a psych ER, I didn't want to be there, it was terrible. So you know what, I'm just going to skip that. It's like, okay, but someone is making decisions based on how you answer the question to survive the system. Then the social determinants of health, look, that's great. It's great that we're doing that. But a lot of our patients, if we think about addressing social determinants of health as a treatment, we have to think that some people have been here for a long time and they've experienced a lot of systems and they may be treatment resistant. You hand them a sheet of every single shelter they can go to, they've tried it and they've been kicked out of shelters every 3 months and they know and it won't that solution doesn't always work for that person, but it's important to know, because when you juxtapose that question with the first one you asked, which is how are you going to pay for today's visit, and you're also asking them about their rent, people can't reconcile what your goal is in their care. And so I think the order is important, the intention is there, but the way we execute it really matters. So this is some trust engineering stuff that we've been doing at Purple. One of the first questions we ask people at check-in is, do you want some water? The reason I say that is because it's twofold, right? It could be a long day, it's just a nice thing to do. The other thing we started to notice is people would be working, they'd maybe come in after an overnight shift, or they haven't really been hydrated, and they're gonna get labs. They rarely get in contact with the system. You have them, this is like your one shot to be able to do the things that they need and that they want to do. But it's so hard to find a good vein because people are dehydrated. And that's not trauma-informed. If you keep poking at people multiple times. So we let people know, do you want to drink water? If there's a chance we do labs, it'll make it easier. Something like that, so people know that the intentionality is around them and their needs and what we could do for them. Similarly, would you like to charge your phone? Every single question is important on the timing of where you ask it in the interaction. You can ask all the ones that I asked before, but at the end of the interaction, it might make more sense than perhaps what's most efficient, which might be in the beginning. So this one, do you need help accessing your results? So literally everyone in the innovation space is almost equivalent for saying, we have an app for that, we have an app. My patients don't have a phone for that app. That's a problem. Some of my patients call from those street phones that we have to say that they're going to be running late for their visit. I spend so much time, and our care navigator spends so much time helping people get their password, get login. The democratization of data for people to be able to access their results is not truly democratic if they don't have the tools in order to be able to access it. And that's where we are trying to invest time to bridge those gaps, because we know that no one is innovating for the people who don't have phones or a Consisto phone. And I'll give you a small pearl. One thing that you might want to do if you're really trying to understand the stability of a patient, ask them how long they've had their phone number for. We opened our new clinic in October 2021, and our patients, some of them have had at least 6 phone numbers during that time. The consistency and the ability to be able to count on basic things that we do to call results, to get pharmacy and other stuff, it's so important to think about people who we're not designing for, or norms we take for granted, so put that there. And then finally, as a trust engineer, you want to understand this question about emergency contact. I could talk about this forever, so I'll do it at the salon. But the emergency contact, it's so interesting for the patients that we see. Often they'll put their lawyer, or they'll put a social worker. They might put an abuser. And we go out of our way to always ask at the beginning of every visit, is this still your emergency contact? Because trust changes. People may trust us differently based on the interactions, but they may trust the people that they're working with differently each time too. And some system that they trust, maybe they don't trust their lawyer anymore because something didn't come through on court. But we need to know that because it's essential for how we deliver their health care. All right, so we'll keep going and we'll follow up on the visit. So we talk about pain points in medicine, and there's these small moments that can invisibilize you in a system. And we talk about protocols, and weight is one of them, actually. So there's a large linkage between history of trauma and disordered eating. So whether it's obesity, whether it's anorexia, bulimia, whatever it might be. But sometimes that protocol and the way we do it and the order in which we have to do it can invisibilize people, because that interaction is what they're dreading. They might come in for a rash, but they're like, nope, we got to take your vitals. But that may not be a vital sign for a patient. So what I do sometimes is I do it backwards. Sometimes I'll see them and then let them know, okay, I need your weight because of this, or whatever it is. Again, the invisible thing in the room that we're fighting sometimes, I think, is efficiency. But I think in order for us to re-earn trust, sometimes you have to change the norms in order for people to be seen instead of invisibilizing them. All right, so we're about to have the patient interaction with the physician. So the 15-minute visit. This is important because people always talk about the difference between equality and equity, right? 15-minute visits for everyone is equality. Customized visits based on your need is equity. It's based on what that person needs. so trust engineering involves math. And somehow someone did math and they were like, if you add an extra person, you can actually make this more efficient. Like having 1 + 1, having a doctor there and a scribe could actually make it so that you don't have to look at the computer, you could look at your patient. It's gonna be great, like burnout levels and all of those things. But the thing is, when you talk about sensitive issues, it's not always adding someone sometimes can subtract trust. If someone wants to disclose something or talk about an issue that they might be having or that they have shame around, having 2 people there can sometimes make that interaction so much harder. And it's funny, one of the patients that I talked to were talking about this presence of a human scribe there so that your doctor can look at you. She's like, it seemed like that court stenographer that I see in court all the time who's sitting there just typing. And I was like, oh my God, like people see other systems that they've engaged in the ones that we're building. And that is just so important to recognize if we really want to engage and see people who are invisibilized in our system. All right, so we have one last try. And this is aftercare. Let's say that the visit went well, but now you've got all the follow-up stuff. Pharmacy, specialist, imaging, labs. And that gap in care is, I know people were alluding to it earlier this morning, that is so important because sometimes the nidus of control ends at that visit. People have so many other ways, right? Whether it's pharmacy pickup, people were talking about that earlier today, the ability to have imaging, specialists, labs, all those things. People are collecting data on who uses that, and then we come up with best practices. If our patients can't make the jump into getting access to all those things, they're getting invisibilized in all of the follow-up care that happens in primary care. So, the thing is, if any of you actually really enjoy Mario Brothers, this is like the best screen in the game. And here's why. Like, this is where all the potential lives. So you're in the first level, Mario 1-1, and yes, there's like a giant gap. But the thing is, there's solutions. We just have to decide whose responsibility is it to fix that gap. There are ways that we can do it, and there's ways we've experimented at Purple, but why even have a gap to begin with? There are ways to make it so that people don't need to learn how to jump it, they just have to walk it, and we can help them. All right, that's fine. But the really cool thing about this is there's access to invisible solutions here if you ask the right questions. So what I think I'm finding in clinic is often I go against what best practices are. If someone comes in for a rash, I just look at the rash, or that's what they tell you to do, right? They're not like, look at your ears, do a full exam because we don't have time. That's not really the best practice. But I make sure sometimes for my patients to be able to do that because they don't often get head-to-toe exams for what they're doing. And all of these different trends start revealing themselves. One of them is traumatic brain injury. So sometimes I have patients come in and they're like, God, I'm such an idiot. Like, I forget things all the time. Things are so fuzzy, or I'm sad. And so we'll put them in therapy. But the thing is, if you take a good history and you understand and you look at different pathology, you start to see, oh my God, this is much more similar to what an NFL player experienced than it is for someone who's been chronically depressed. That changes the outcome. That changes the type of care plan that I'm going to come up with, but we miss those things if we don't spend time. So you have to have the curiosity to figure out these, what I call one-up moments. These times where it's like, I'm going to discover something that actually could change the field if you have enough time and curiosity to figure it out. So that's one thing. The other thing, though, is this opportunity to collaborate with the people that you are creating the metrics for. So one of the things is if you do trust engineering correctly, you can actually start finding out from your patients the things that matter to them and what are the things we should be measuring and what do we want to measure. So I'm going to leave you with this final clip, and this is what it could look like. Whether that's discovery of new primary care, best practices, whatever it might be, collaborating with our patients, one of the things we do now is we actually start asking patients, do they have a bank account? Can they keep their minimum? Do they know their credit score? Because we understand that it's not just about avoiding medical debt, it's about helping people build wealth. And medical care can do that. Healthcare systems can do that if we think beyond the silos we live in. So we can get to this final point where patients are able to actually meet the goal that they're looking for. And the way we define that goal is where the system meets the patient's quality metrics. And I hope that this is a helpful example for how we can engineer trust into the people who are invisibilized in our systems. Thank you so much.
It's time for more salons. So this time we mean it. We are going to reconvene at the time we say, 1:45 back in here. If you want to see Anita or Nzinga or Aaron, please follow the signs down the hall. We'll see you back here at 1:45. Food is still available. Feel free to take a plate into any speaker salon and move between salons as you wish. 1:45. Thank you.
Quality Talks is brought to you by several generous organizations. NCQA thanks Platinum sponsor Merck for an independent educational grant to support this event.
Welcome back to our Quality Talks live stream. I'm Dr. Nick, and what a show it's been so far. Important messages from Dr. Harrison, Dr. Neinstein, and Dr. Ravi. And we're still not done. Ahead, now, on our live stream, more in-depth interview with Quality Talk speakers, NCQA scientists, and a whole lot more. While you grab your lunch, keep us here in front of you on this block. We have visits from Dr. Nzinga Harrison, Dr. Ben Kligler, Jennifer Goldsack, and Dr. Suchi Saria. All that and more coming up. Now, in a few minutes, we'll be talking with NCQA Senior Research Scientist, Dr. Caroline Blaum. She's involved with so many different projects and priorities here at NCQA. One of them is patient-centered outcomes. This is a big one for us. With many of our topics of conversation today improving equity through digital health tools, they're all point to reorientating the traditional doctor-patient relationship. Here's a look back at the story of one of NCQA's patient partners, David White, and his view of patient-centered outcomes.
It really began about 11 years ago when I wasn't feeling very well. My wife knew that something was seriously wrong with me, and she said, you know, we have to get you to the emergency room to get you checked out. Once they did draw blood, they found out pretty quickly that something was really wrong with me. And it didn't take long for them to figure out that something was really wrong with my kidneys. And in fact, they were very close to shutting down completely. Before that transplant, I had to spend a total of almost 6 years on dialysis. I wanted no part of dialysis, and I took it out on the people at my dialysis clinic. I was supposed to go 3 times a week. But I wouldn't. I was actually putting my life in even more danger until I had a personalized care plan meeting with the people at my clinic. They said, David, you're not trying hard enough. What happened at that meeting that really saved us is that they did a root cause analysis to find out why I wasn't going. April 10th, 2010. That meeting literally saved my life. At the end of the meeting, the charge nurse said, okay, like these are your marching orders, but it's not going to work unless you do your part. Those words really hit home. From that day on, I went to dialysis 3 times a week, no matter what. That's the day that I became engaged in my care. That's the day that I realized that I have a hand in my health outcome. I became part of the healthcare team, and it took a while, but eventually I became the captain of the team. For me, a person-driven outcome that is really personal is how many push-ups I can do. On New Year's Day, 2011, I couldn't do a single push-up. But that year, I wound up doing over 15,000 push-ups. At the end of this year, I think I'm going to be somewhere between 160 and 170,000 push-ups. It's my life, so I should have a role in the decision-making process whenever possible. Especially since I know what I want to do in life. Like, my goals and my values should be honored, and whenever possible, like the care, whether it be prescription or a modality, it should be tailored to match my goals in life. Let's say, I don't care so much about living a long life. I just want to be able to have an active life. That's something that the person who's taking care of me should know, because that may affect the prescriptions that I'm given, and that will definitely affect our discussion. I can tell them, if we use this method, things that they wouldn't think of, and that will actually make their job easier and make it more rewarding. They're touching people's lives and not just taking care of them. Take my example. This person, we treated him the way we treated everyone else, and he almost died. But when we took the time to find out what he really wanted, look what happened.
Dr. Caroline Blaum is the Senior Research Scientist for Performance Measurement. Caroline has helped craft so many products and policies for the NCQA over the years, it's hard to know where to start. Caroline, welcome back to the show.
Thank you. Glad to be here.
Give us an update on NCQA's efforts towards person-centered outcomes.
Well, I think as we just heard from David White, person-centered outcomes is outcome measures is a project that I've been working on with NCQA since I came here about 3 years ago, and NCQA teams have been working on for 6, 7, 8 years. And you just heard from David White, we've always had, so the entire time NCQA has been working with this, we've had patient partners helping us all along the way. And David's been with us for about at least 6 years and been a source of inspiration and a source of information as we work on patient-centered outcomes. Patient-centered outcome measures are measures that are designed for patients who have complex health needs that measure the type of care that is consistent with what matters most to them. We believe that most patients, but especially patients with complex health needs, should have the care they want, should have the care that allows them to achieve the health outcome goals that they really want to achieve. We call that care that matters. And we have developed a way to measure that. That's what NCQA has been doing for about 6, 7 years with this. Again, supported by some sponsors. We've been very lucky to have sponsors from the John A. Hartford Foundation, the SCAN Foundation. So over the years, we've developed a way to measure this kind of quick care, and not only to help these types of patients, but also to reward the clinicians eventually, to say, to drive this type of care that clinicians want to give and the patients want to get. So an update, it's tricky to develop quality measures that really are focused on the voice of the patient. It's not done very often. A lot of them are labs or this or that, claims, bills, but not often do quality measures involve the voice of the patient. It's actually a little bit tricky to do it. That's why it's taken so long. But I'm really happy to provide an update that we have tested these now for several years, and we are now in our final stages of testing with some learning collaboratives across the country. And we've tested these types of measures of patient-centered outcomes of care that matters in lots of different types of care delivery systems and with lots of different types of patients. Older adults, people with serious illness, people with behavioral health problems, and it's been working in various areas of the health system, so we're very happy about that, and we very much are happy with the clinicians and the patients who've helped us test that. So that's what we're in the middle of doing right now, and we're very happy with that. We're having very positive results.
So we hear a lot about different versions of this, patient-centered, patient-centric.
Yeah.
Can you clarify some of those different terms that we see in here?
Well, different words get... No. I mean, these words are used, they're sort of bandied around and thrown around. And what we think about our person-centered outcome approach and our person-centered measures is let's look at what they do, not what they're called. We do believe that they really are measures that get at care that the patients want, that matters to them, and it really is the voice of the person and of their caregiver who's also involved. So that's why we call them person-centered outcome measures. But the important thing is to look at the type of care that they drive, the fact that patients are involved, caregivers are involved, with their providers and their clinicians in shared decision-making about their care.
Would you say that this is a big shift from the historical status of medicine where, essentially Patelamus, said the physician is at the center of the universe and everything orbits around?
Absolutely. It's a culture change. And I will give the clinicians some credit. Many people who are taking care of complex patients in the last 10, 15 years have realized that they can't make decisions for patients. There's never going to be enough evidence for complex patients. And there's so many choices and so much care. It really is about what the patient wants out of their care. So clinicians have come to this, but it's still a culture change. It's not how they're taught. It's not how they're trained. We think sometimes the social workers may be a little better at it than the doctors, and the nurses may be a little better at it. But, the clinicians can get it. The one thing that we do know is the patients can get it. When you start to explain a patient and say, well, what are your values? What do you want to get out of all this care you're getting? What's really your goal? The person gets very engaged. They understand why that some of these things are being done, and they can articulate to the clinician, what I really want to do is be able to, go fishing. What I want to do is be able to garden. How can you help me get my health in shape so I can do what matters to me? And that's the kind of care. It's a little bit of a frame shift. So, and it's a culture change, but I think it's a culture change that that's coming. I think a lot of people are thinking about it.
So patients are not just walking, but they're running towards this patient-centered care.
It's true.
I think that's good news. A little bit of time left. Tell us about digital therapeutics, if you could.
Okay, it's a little bit of a difference, but not that much. One of the things that we're very interested in is access to care and access to the right care at the right time. And of course, because of the pandemic, there's been a lot of talk about virtual medicine and telehealth, and again, lots of different words that mean different things to different people. So NCQA and I myself am very interested in how, in the quality, what kind of quality, what should be the expectations that people and patients can have when they're working with digitally enabled care models. If they get an app, how do they know it's a good app? If they're seeing a doctor, virtually that they got online, how do they know that person is credentialed and knows what they're talking about? So there's a lot of questions about this industry because it's grown up so fast. So that's one of the things that we're exploring with many experts around the country. NCQA always works by consensus. We're getting lots of input, trying to understand so that stakeholders, the patients and payers and, other health systems can figure out how technology-enabled care fits in.
So it feels like a lot of trust issues, importance in terms of bringing all of these things together.
That's right.
Exciting times, I think. Great progress, quite frankly,
Yes.
to see that move. Caroline, thanks for joining me today on the show.
Thank you. It's been a great conversation.
Racism is an addiction. The symptoms, behaviors, and yes, even the treatments and cures for any addiction can be applied to racism. So says 2023 Quality Talk speaker, Dr. Nzinga Harrison. Are you intrigued? I know I was. Take a deeper dive. Here's a taste of episode 103 for NCQA's podcast, Inside Healthcare.
We take the very broad definition of addiction as a behavior that we continue to engage in despite negative consequences. And if we take the concept out of the individual person to a societal concept, then I think we could all agree that racism is a societal behavior that we continue to engage in despite negative consequences.
Check out our Inside Healthcare podcast, available at blog.ncqa.org or from any Apple or Google streaming services. At NCQA, we're serious about healthcare quality. we use science and metrics to help bring better healthcare to all. Today is a special opportunity to let folks know what we're really all about. Have a look at this. Find out more about NCQA, our products, trainings, and so much more at ncqa.org. We move on now to a chat with one of our newest Quality Talk sponsors. Our next guest is Albert Ihochi. He's head of strategy and operations at Kintsugi. Our guest advises tech companies on growth strategies and operations. In the past, Albert oversaw the launch of numerous products for billion-dollar healthcare and software brands. Now, he's with Kintsugi, helping develop ways to use vocal biomarkers for mental health screening. Albert believes that mental health is criminally underserved in today's global society. He's seen the difficulties of dealing with depression and anxiety. That's why he wants to scale mental health to those in need. Albert, welcome to Quality Talks.
Thank you very much. It's a pleasure to be here.
So can you tell us more about Kintsugi? What's the company's mission and goals, and perhaps a little bit about the term?
Yeah, absolutely. So as we all know, and has been a big focus of the conference here this week, mental health and mental health challenges is a huge problem in the United States as well as globally. We know that every year, tens of millions of people in the U.S. suffer from various mental health conditions such as depression and anxiety, but only less than 4% of them are actually identified with those conditions by their primary care provider each year. And this creates an enormous cost burden for the cost of undiagnosed mental health conditions. It's up to $200 billion in the U.S. alone. And so our mission is to scale access to mental health care for all. The way that we help do this is we've developed voice biomarker technology that uses machine learning to identify signs of depression or anxiety from short clips of free-form speech. Our technology has been clinically validated and has been deployed in a number of different use cases and leverages an API-first platform so that it can be integrated into existing clinical workflows, whether you're a payer, a provider, or another healthcare partner.
So when you talk about biomarkers, you know, that's an indication from listening to a voice. It sounds like it's a small piece of voice. Yes. You can add this in anywhere. Where are some of the places this is being applied?
Yeah, it can be applied in many different types of use cases. In some cases where we've worked with, say, for example, a very large health insurance provider, we implemented this technology in some of their call centers as part of wellness checks or as part of other routine medical calls. And we are, with consent, listening in the background seamlessly, so there's no disruption to the clinician-patient interaction. And we can identify, and as you mentioned, using short lengths of speech, those signs for clinician follow-up and aftercare. In other situations, we can use our technology to ongoingly monitor patients around their mental health status for like remote patient monitoring applications. And it can be implemented in all sorts of use cases, whether they're call center, whether they're telehealth, or even real clinician interaction.
Well, so as I think about that, that's the 96% of the people that are not getting that diagnosis. Important times, important opportunities to be able to provide additional insight and obviously treatment. Albert, thanks for joining me.
Yeah, absolutely.
By now, you probably have something to say about today's speakers. Share your thoughts on digitalization or health equity by connecting us on social media. Let other Quality Talks viewers hear what you are inspired about and allow us to think deeper about healthcare today. To get you going, here's another thought question. As clinicians gradually focus on patient-centered healthcare, What do you think will be the most significant long-range outcome? And tell us what you think. Find us at NCQA on both LinkedIn and Twitter. Throw us a post. Remember to include the hashtag QualityTalks2023. Now, I'm excited to welcome Dr. Ben Kligler. He's the Executive Director of the Office of Patient-Centered Care and Cultural Transformation, an important part of the U.S. Veterans Health Administration. Dr. Kligler has spent nearly 30 years advocating for the use of acupuncture and other non-traditional healing methods as a treatment for chronic pain. Dr. Kligler, welcome to Quality Talks.
Thank you. Glad to be here.
Tell us about the office's mission and the goals for your Veterans Administration.
Well, my office's mission, my office has in its title the word cultural transformation, which is a bit grand, patient-centered care and cultural transformation. But what we're working to do in the VA is actually push forward a concept called whole health. Whole health is the idea that it's time to go beyond just disease-oriented care and really think about the whole person and what matters to them. Now, part of what we're doing is pushing forward some of the complementary integrative health approaches that are now part of VA care. So those are things like acupuncture, yoga, tai chi, meditation. These are part of expanding the toolbox so that veterans have more options in terms of how to really get at what's most important to them in their life.
So, I mean, I'm a big fan. I practice some, maybe not all of those, but, you know, clear value proposition, quite different to traditional medicine. How has that been accepted? What's been the response?
I'd say the response has been tremendously positive. We have, of course, some fairly conservative traditional folks, particularly some of our older physicians in the system who are haven't had an opportunity to really be exposed to some of this idea of a bigger toolbox. They didn't necessarily learn about it in school. They haven't encountered it in their practice. So obviously there's still a lot of learning to happen. But the idea that we need an approach to care that really looks at the whole person. Veterans have, as a population, a fairly complicated set of interweaving problems, as you can imagine, physical, mental health issues, et cetera. And so the standard kind of problem-based way of addressing their concerns hasn't always been the most effective. And so I think the system is very open to this idea of how do we look at the whole person and how do we help empower them to make the changes in their life. So I'd say the response, we had over 1 million veterans in last fiscal year, in fiscal year 22, who used whole health in some form or another. So that's about 16% of folks who are using the VA. So pretty good uptake.
So what successes have you experienced in spreading the idea of whole health across the Veterans Administration?
Well, we've seen a number of benefits for veterans. For example, veterans who are using the whole health approach have been able to decrease their use of opioids for pain much more rapidly than veterans who have just been using the conventional approach. That's one benefit that we've seen. We've also seen increases in their quality of life, physical and mental quality of life. We've seen increases in what you would call engagement with healthcare, so people really taking charge and working on what they can do for themselves. And most impressive, I think, is just the stories we hear from veterans about how the conventional approach, the conventional disease-oriented approach was just not getting them there. And once they encountered this idea of whole person care with a bigger toolbox, they've really been able to get unstuck with their lives and get back to where they want to be going in their lives.
So I have to ask, I mean, veterans health suddenly stepping into into integrated health. How did that come about? What was the journey there?
Yeah, I think combination of factors. I think number one, the complexity of our population. Number two, the incredibly strong commitment in the VA to the mission of the system, which is whatever it takes to take the best care of veterans, that's what we're going to do. So people, leadership, and also clinicians in general are really willing to go beyond what they're used to if it's going to potentially make a difference. I think the other thing that's really happened is the evidence base for some of these approaches, like take acupuncture, has really exploded in the last next 5 to 10 years. And so it's easier for people to feel comfortable now that there's evidence for effectiveness for some of these things. Combination of factors, I think.
Ben, thanks for joining me on the show today.
My pleasure. Thanks for having me.
Quality Talks is such a great opportunity for folks to see NCQA as we always have been, dedicated to focused on using science to improve healthcare for all Americans. All in one day, we open the stage to 10 unique speakers, each with only maybe 15 minutes to inspire you to think and motivate you to action. In addition to this annual event, we also offer an incredible 3-day conference experience, the Health Innovation Summit. The Health Innovation Summit is the place to inspire and accelerate healthcare quality, bringing together leaders across the healthcare ecosystem. The summit will focus on all aspects of quality, including digital solutions, health equity, value-based care, and much more. Just watch. Andy Reynolds is the Assistant Vice President for External Relations at NCQA, and once again, the onstage host of Quality Talks. He's here to give us a peek behind the curtain in what it takes to throw this all together, throw being the operative word. It's a big experience for everybody. Maybe he'll give us some backstage gossip from this year's show. Andy, thanks for being with us.
Thank you, Nick. Good to be with you.
How do you select the Quality Talk speakers?
It really is a two-way process. For some speakers, we just know of them, we admire their work in healthcare quality, and we just decide we want that person. And that's kind of a bottom-up process where we identify the player, so to speak, and say, let's figure out where to put them on the team. Sometimes it's the opposite. It's more of a top-down approach where we identify a theme or a general topic, and we say, okay, who best fits under that general umbrella. So I think of it as kind of a pincer movement, some top-down, some bottom-up. It essentially is a way of finding the best people to talk about the topics that we at NCQA think are most salient or important with regard to quality and value.
So for the listeners out there, can they nominate people?
We do take suggestions. The easiest way to recommend speakers is to contact us at qualitytalks@ncqa.org. Mainly, it's important to keep in mind that we're interested in people who can do this format. In many healthcare conferences, you see a PowerPoint parade, a lot of conventional reading of slides, and, oh, the figure on this slide turned out a little small. I'm not sure if you can see it, but what we did was a study. This is not that. We strive to bring communicators who really have a knack for storytelling and who are terrific on their feet and can impart the passion they bring to their work in this unique format. So that is a key criterion for speakers in getting to Quality Talks.
That sounds like a little bit of backstage gossip right there, because based on what I've seen, very little PowerPoint, actually. There's more in just in terms of speaking. What else should the viewers know about in terms of NCQA Quality Talks?
Well, I think Quality Talks is a fascinating counterpoint or contrast to the other event you mentioned, Health Innovation Summit. Health Innovation Summit is really a terrific superstore, multi-day event for all things that NCQA is doing right now and future topics. Quality Talks is more of a big think boutique event, if you will, where we're really featuring the big thinkers, and you take the two together. A lot of practical knowledge to be learned at Health Innovation Summit. The ideas and inspiration from Quality Talks, put it all together, they really work as a portfolio or as a combination. I think that's the most important thing to keep in mind about Quality Talks, its special role in our event series.
Closing seconds, how do they engage with NCQA?
As always, the best place to start is ncqa.org, the website.
Andy, thanks for joining me today.
Thank you.
We're almost ready to rejoin our main stage Quality Talks. For another brief look back at Quality Talks of the past, take a look.
And we know we live in an increasing depersonalized world of electronic communication, emojis, lots of technological advances. What's going to work? What isn't going to work? What do we apply? What is just a lofty idea? With all of this movement through lots of depersonalization, kindness may seem unimportant. But in fact, kindness indeed is important to patients.
So we're here at NCQA, and so of course I have to talk about measurement. And I want to ask all of you and all of us, because we know that what we measure reflects what we value, and it drives what we do. So we're working to think about measurement that reflects the questions that matter to us. Do our members trust us? Will they keep coming back to us? Will they grant us the privilege of deeply and fully understanding what matters to them? Will they listen when we recommend, suggest, or nudge behavior change, treatments, interventions? Will they turn to us before going to the emergency room? Our success depends in a value-based world on our ability to earn and sustain trust. Therefore, we have to be able to measure it and drive towards it.
Way too many quality outcomes and quality goals, as well as the economic system incentivizes disease management and disease maintenance over disease reversal. So my call to action is, I think we absolutely have to make sure that quality measures and the economic model incentivizes disease reversal where possible.
Welcome back. Now I'm delighted to be welcoming Jennifer Goldsack. She is the founder and CEO of the Digital Medicine Society, better known as DIME, a non-profit dedicated to advancing digital medicine to optimize human health. Jen earned her master's degree in chemistry from the University of Oxford, England, her master's in history and sociology of medicine from the University of Pennsylvania, and her MBA from the George Washington University. And she's also a proud Olympian, having rowed for the US at the Beijing Olympics. Jen and her team are dedicated to advancing health equity through digital transformation by using what's already out there to make the healthcare changes we need right now. Jen Goldsack, welcome to the show.
Thrilled to be here, Nick.
So tell us about the Digital Medicine Society, or DIME as you call it. What's your mission?
Our mission is to advance the ethical, effective, equitable, and safe use of digital technology to redefine healthcare and improve lives.
So as I think about that, we've had digital enablement.
Yep.
Where are you playing? What's your contribution to this whole digitalization of our healthcare world?
Where we believe that we're strongest is by determining the evidence we need to be able to build trust in the digitization of healthcare. I think there are a lot of assumptions made about the level of trust that end users, whether they're patients themselves, whether they're clinicians, healthcare systems, payers, even regulators, there's going to be sort of a blank acceptance of these new approaches. What we recognize is that trust has to be earned, and we need to be able to demonstrate that these new approaches, whether they're products or whether they're services, are actually improving healthcare, that they are safe and they are trustworthy and they are effective.
I know our viewers are going to want to know this. How does an Olympian rowing athlete end up in digital medicine?
Apparently, I really like hard problems. I would probably.
Rowing's hard?
I mean, you know, some people might say it is. When I retired from the Olympics in 2008, as you might remember, the economy was absolutely in the toilet. I found myself in Philadelphia and was thinking, you know, where am I going to put my research skills to work? Ended up working at the University of Pennsylvania, and it was at the hospital there, and it was such an extraordinary time. We had the passage of health reform, the HITECH Act was implemented. We were really starting to think about the digitization of healthcare and new ways of evaluating healthcare. Throughout the course of my career, whether it was was at Penn, whether it was in a pragmatic research institute that I was lucky enough to co-found, or whether it was the work I subsequently did on the clinical trial side of the house, I was lucky enough to always be at the forefront of people thinking about digital and thinking about implementation at scale. So it was more by luck than good judgment, but I feel passionately that, you know, while I don't think tech is a silver bullet that's going to help us, you know, solve all the problems we have a once in a career, probably once in a lifetime opportunity to reimagine what it means to care for people using these digital tools in the toolbox. We also have an opportunity at this moment in time to get it right out of the gates, to do it in a way that's trustworthy, evidence-based, and effective. That's what we focus on at Dime.
So in the remaining seconds left, tell us how you focus on the equitable use of digital technologies, because that's where the big discrepancy seems to come.
Well, let me flip that on its head, because you know what's not equitable today? The current healthcare system. And so what drives me, frankly, I'm going to use a word that you're like, bonkers, is, you know, people are like, oh, you know, should we move forward with digital? You know, what about health equity? And I'm like, what about health equity? It's absolutely terrible. We have one of the most inequitable systems in the world. And so we like to flip that question on its head and say, as we digitize healthcare, as we go through this watershed moment, this transformation, how do we make sure we are bringing everyone with us? How do we make sure that every digital innovation is actually improving lives for all people, not just the lucky few? That's the way we tackle it.
Important insights, important organization that is really pushing equity. Excited to have you here with us. Jen, thanks for joining me today.
Delighted to be here. Thanks, Nick.
If you're enjoying Quality Talks and want to hear more, you can get exclusive interviews with many of our presenters. For example, Dr. Suchi Saria, one of today's foremost experts in artificial intelligence, came on our show recently to talk about getting AI into healthcare. Here's a peek from episode 103 from Dr. Saria on NCQA's podcast, Inside Healthcare.
We're now moving into this new age where, because of electronic infrastructure, we're capturing data everywhere, far more than we did almost a decade ago. And that opens up this possibility of understanding an individual human, their health and their disease state, which allows us to move from a proactive, into more of a proactive system of care, which is both better for patients, better for caregivers, because it leads to less burnout, better experience, lower cost. So it's all of the things that we wanted, but not had the ability to do.
Lots of talk about digital health at Quality Talks this year. Some speakers have helped already to define digitalization for us. But when you put together digital health and NCQA, what do you get? And how do we move from a paper-based workflow to a digital one? Here's some answers. Watch closely.
Hello, I'm the Healthcare Effectiveness Data and Information Set, or HEDIS for short. Recently, NCQA has started making some of the biggest upgrades in my history. My measures are going digital. Digital measures bring new ease and clarity to assessing quality. Here's why. For years, computer programmers who work for health plans have had to translate HEDIS measures into computer code that extracts healthcare information from databases. A big job. Because HEDIS measures have been written in words and not in computer code, the measures could be misinterpreted, especially by people new to reading quality measures. In fact, it looks like a software engineer is reading me right now. Uh-oh, it might take them a while to understand me. Different programmers might understand me differently and program me differently. That's a problem because it makes it hard to compare results between plans. To ensure consistency and apples-to-apples comparisons, NCQA has begun to write measures using a standard digital language. People who aren't programmers can read the measures, but the language is still precise enough for computers to use. Before we take a closer look, check out my new size. I've lost a lot of weight. Now that my measures are digital, I've slimmed down and fit inside a zip folder. Programmers can download me from NCQA and plug my code straight into their computers. It's fast, easy, and doesn't require interpretation. Programmers like to know about the two main parts of my digital format. My quality data model, or QDM, contains the basic elements that comprise a quality measure. Things like procedures, patient encounters, and lab reports. My CQL, or clinical quality language, is the logic that ties those elements together. Here's an example of a digital measure in action. This measure's CQL code tells the computer to look for patients who have a diagnosis of pharyngitis or sore throat. The CQL can tell the computer to look for a specific time range, illness severity, and other data. Then the data can be combined with other CQL classifications, such as doctor visits or medications. If we want to find office visits when the patient had a sore throat, we write it like this. Then the computer looks for these diagnoses in the database. After a measure's data elements are written in CQL, they are translated into file formats that computers can use to calculate and report HEDIS results. So here's what's inside me, or my zip folder. A human readable file, this makes me easily understood by people who aren't familiar with computer-coded files. A CQL file, this is a list of all my data elements written how a computer understands. An XML file, this is a machine-readable file that stores and transports data. And a JSON file, this is a JavaScript file. It's included because some computers read JSON files easier than XML files. I can't wait to show off my digitalized measures to health plans and others who work with HEDIS. I know they'll like the new digital me. Going digital brings new ease and clarity to working with HEDIS. Look for more news about digital HEDIS as NCQA creates even more digital measures.
Such incredible guests, inspiring content today. I know I've been inspired. I hope you've been inspired on the show set as well. Coming up, the final group of speakers for today's event. But the show doesn't end there for you. We'll continue our live stream until about 3:30 today. After the next block, you'll meet NCQA's first Director of Health Equity Initiatives, Dr. Bryan Buckley, plus close-up chats with Dr. Neinstein and Dr. Ravi, and more. Equity, remote care, digitalization. Don't go anywhere. This is Quality Talks 2023.
There's more Quality Talks just ahead. Next topic, homing in on better care and better health. Dr. Pippa Shulman, Dr. Ben Kligler, Dr. Liz Kuo, and Jennifer Goldsack take the stage. Stay right there.
seamless workflow. MCG is currently used by thousands of hospitals, a majority of U.S. health plans, and is widely trusted as a common clinical language by payers, providers, and government agencies. Learn more about how MCG can help support quality and efficiency in healthcare decision-making at mcg.com.
Life-changing is what drives us, all of us. At UPMC, we believe life-changing medicine can't wait, and that our breakthroughs are only as good as the people they help, serving more than just patients and members, but whole communities, to change the future of health for everyone. Because only then can we call it life-changing medicine.
If you were clapping for the video, imagine how fun the real thing will be. Welcome back. We're in the home stretch. Our next speaker has been on Twitter longer than Elon Musk has. And she is a self-described space junkie who went to space camp at age 40. Now, NASA took notice of all of that, and that's why NASA invited her to be an official tweeter for one of the last space shuttle launches as an act of citizen journalism. Down here on Earth, we know her at NCQA as one of the most dynamic leaders in the growing category of care at home services. Please welcome Pippa Shulman.
Twitter's a lot less fun than it used to be, unfortunately. I'm here to tell you that I am part of a big problem. I'm part of a system that has hidden the benefits of home hospital from a vast majority of the public. I'd classify it as a cover-up. Don't believe me? There's a lot of doctors in the crowd today, nurses, nurse practitioners. Ask them how many of you have kept a family member out of the hospital? Brought home a vial of something, hung some fluids in the living room? I will tell you, it's all of them, or at least almost all of them. I did it for my mother. I realized in the green room, it's 20 years ago this month, I drove up to an emergency department where my mother had been admitted after getting lost in the Target parking lot. Turned out she had a very large brain tumor that even a baby doctor like myself could see on the actual film they put on the light box. She got admitted for a life-saving surgery and then had a pretty prolonged hospital stay. Finally was discharged home on a beautiful day in May. And this tree in her yard was blooming. It's a Carolina silver bell, and the one they had in their yard was huge. And when the flowers come off of it, it snows, this pink-tinged snow. And she was so happy to be home. And she said to over and over and over again, I don't want to spend more time in the hospital. And so she didn't. Now, don't get me wrong. She had 2 years of therapies aimed at prolonging her life. And I made sure she went to all of her oncology appointments, all her treatments. But when the side effects of treatments threatened to land her in the hospital, when she got a fever, I made sure she didn't end up there. And she never spent another night in the hospital, even as she was receiving active treatment. So why hasn't home hospital scaled? Why isn't this care available to everyone? Well, part of it is our fabulous system that we've put together. And one of my mentors always said, every system is perfectly designed to get the results that it gets. So think about it. You have a new illness, or you're a patient with chronic illness, and you have a new symptom. And so you go to your PCP or you call somebody. I've been a PCP. It's a very difficult job. And they're overburdened and busy. And so maybe they can't fit you in, or they can't even get on the phone, or maybe you don't even call and you're directed or you self-direct to the emergency department. And we've all seen what the emergency department looks like. And by the way, it looked like that before COVID. COVID just made everybody pay attention. And so now you're in the hall, it's crowded, and if we are worried about you at all, if you are a risky patient, and if you're over 65, that makes you risky, you're getting admitted upstairs. And now the facility has swallowed you up, right? And the hospital's great. We can do all kinds of things there. We can order every test under the sun. We can consult our 97 consultant friends. Do we get clinically actionable data out of all that? Jack Wenberg and a generation of researchers at Dartmouth have shown us that in healthcare, unfortunately, it is supply that drives demand and not the other way around. And so this system perpetuates itself, and after about 3.5 or 4 days, you're discharged. 20% of the time or more, you're discharged to a skilled nursing facility. Otherwise, you go home and you have some confusing instructions and you're allowed time to heal. And the system repeats itself over and over and over again. And we know this doesn't work, and we know that readmissions are high. There's got to be a better way. So who here wants to go to this hospital? You're all like, no. I don't see anyone raising their hands, right? Why is that? Even when we go to the hospital for a happy occasion, like the birth of a child, we bring bags of crap with us. We bring our pillows and our pictures and flowers and outfits and all kinds of stuff that, by the way, you probably don't need, but it's all to create the different environment. We did that for my mom. We had the blankets and the radios and the pillows and the flowers. My dad set up a bar in the corner, I kid you not, to greet visitors. Now you have some insight into my family, but we'll move on from there. But we know that we don't like the food, the beds are uncomfortable, and the nights are really long and lonely and scary. There's this incredible paper that colleagues from Mayo Clinic and Duke published in the Annals of Internal Medicine in 2020, and it, as the kids say today, it lives rent-free in my brain. It was comparing the experience of hospitalization to enhanced interrogation, as described by the CIA manual on the same topic. The conclusion was that a hospital stay resembles torture. Torture! You think I was provocative earlier, how about now? Is it true? All right. So you go into the hospital, you go into that ED that we talked about before, people start asking you questions, all kinds of different people, and they ask you the same questions in different ways over and over and over again. And they throw in just enough medical jargon that you may not understand what they're asking you or why. And then we take off your clothes and we give you a uniform. And that uniform barely keeps you warm and does not offer you a whole lot of modesty, if you know what I'm talking about. You're put into a room where you do not control the lights, the temperature, the schedule, the food, and you're taken at all hours of day and night for procedures and tests. And you never know when the person in charge is coming. We know that hospitalizations and repeated hospitalizations have created this syndrome that's now in the literature called post-hospital syndrome, that's characterized by post-traumatic stress disorder, anxiety, depression, sleeplessness. Now layer on top of that, if you're in a vulnerable community, if you are a person of color, if you are part of the trans community or other queer patients, if you are a rural patient or poor or have mental illness, who already the system has mistreated you in some way, and now we have taken away all of your autonomy and personal control. And this leads you, all these groups are at higher risk for complications from that hospitalization, and it's not just readmissions. So how could this be different? 20 years of data has shown us that there is a better way. Home hospital is not new. I didn't invent it. It's been around a long time here and across the world. Great study, Journal of American Geriatric Society, showing rates of delirium in the home hospital compared to bricks and mortar cut by almost half. Falls decreased, Hospital-acquired infections, guess what? Your own dirty house doesn't give you the same infection the dirty hospital does, that's for sure. What about pressure ulcers? Functional status. Readmissions is something we talk about a lot. Study after study after study, including large meta-analyses, show that readmission rates in the home hospital are cut by, it's a long range, but on average about half compared to the bricks and mortar hospital. Mortality. Again, multiple studies, including one just published by Mayo Clinic, shows that mortality is lower in the home hospital than the bricks and mortar. Oh, well, you're cherry-picking patients. Guess what? We have ways that we can compare severity of illness of patients in the home hospital and patients on the bricks and mortar, and they're the same, and sometimes even sicker. We also look and make sure, for our programs, we want to make sure that we're taking care of the widest range of patients. And so we look at payer status, we look at neighborhood deprivation index, and make sure that matches the home hospital. So again, I ask you, why is this not bigger? Why are we doing for our own families what we're not doing for everybody else? And I will argue it is the culture. There's a hospitalist in Knoxville, Tennessee, and their hospital about a month ago opened a new home hospital program. And it's going to be spreading across that region over the next 2 years. This hospitalist was part of a group of physicians that were voluntold that they would be participating in this new model. This was not someone who was a champion of the model and came in with a healthy amount of skepticism to training. Did come to the training, which was step one. And after the first patient, we spent some time interviewing the physician to see how it went. And they said, look, I was going to do my best. Thank you. But all I could think about coming into my shift that day was what I couldn't do in the home that I could do in-house. Their first patient was a late 70s, early 80s-year-old woman who'd had multiple hospitalizations. She had a bunch of chronic medical issues, and she had a relatively uncomplicated stay. She needed twice daily intravenous medications, daily labs, meals, some nursing care, sort of the usual things that we provide in the home hospital. And on her day of discharge, the physician took the time to ask her how her experience had been. Now, when's the last time, by the way, that a doctor has ever asked you how your stay has been? I just love that they took the time to do this. And she loved it. And we see this all the time, that the virtual hospital or the home hospital is the best performing hospital in a systems network. And she said, oh, I got to sleep. And you responded so quickly to everything that I needed. And the physician said, and I realized she'd never had a good night's sleep in-house, and she never felt like she had control over the situation. And it would have seemed insignificant to me for her to be separated from her pets, but she got to be around her pets, and that was so important. And he said, the next time I went into the hospital to do a regular bricks and mortar shift, all I could think about is what I couldn't do in the hospital. Because when we see patients in the hospital, they are two-dimensional figures in a bed, no matter how much we try to create that connection. But when we see people in their homes, see how they really live, when I can, even on video, what's on the table next to you? Who's with you? Who's not with you? Is it cluttered? Is it clean? What are you eating or not eating? How do you actually take those medications? Because I love the speaker before said half of the people don't pick them up and take them, or they're picking up multiple prescriptions. That is the opportunity, and we see this over and over and over again. We're partnered with a group at Mass General Hospital that's doing home hospital and actually decentralization of all of acute care for blood cancer patients nearing the end of life. So really, there are acute visits, urgent visits, hospital visits in the home, all while receiving active treatment. In the control groups, 80% of the patients in the control group, 80% of their time is spent in the hospital, and 65% of them die in the hospital despite a wish to die at home. And when we decentralize away, they report symptoms earlier because they know they aren't going to be forced to go back in-house and lose time with family. And 80% of their time was spent at home. And more than that many got to stay home while receiving active treatment. And that is the power and the opportunity. And that is the moral imperative on us to acknowledge that home hospital is not just the same care delivered at a different site. For many groups of patients, 30%, 40% of what's in a bricks and mortar hospital now, it's actually better care delivered in a better site of care. So now I have a call to action for you. This is a really exciting and distinguished audience. I want you to go home and understand why or why not is home hospital allowed in your state. Because guess what? We now have waivers under CMS that will allow payment. Payers are starting to catch on, but states are, in some cases, saying this is not permitted here. In some cases, they are. Ask why there is such a variation in licensure across elements of our workforce that is so needed to expand to be able to make home hospital stronger. Home hospital is a team sport. It's one of the best things about it. And ask, and we have payers in the room, so ask yourselves, but ask your payer and ask your doctor if home hospital is right for you or your family member. Because it is time for all of us to demand what is good for our families should be available for all families. Thank you.
Our next speaker is someone who is literally changing the conversation about what good care is. What's more, he's doing that at scale inside the country's largest integrated delivery network, the Veterans Administration. He's having success changing the definition of high-quality care, and we're pleased that he's joined us here at Quality Talks. Please welcome Ben Kligler.
So when you go to see your primary care doctor, what's the first thing he or she does? Pull up your problem list. And we all, I think, probably know what the problem list is, but in case you don't, the problem list is just that. List of every concern you've ever come to your healthcare team with over the years. So it might have your hypertension, insomnia, back pain, depression, diabetes, whatever it is over the years. Your physician feels that his or her job now is to work their way down the problem list and check off the box next to each problem. Every problem needs to have a treatment plan, a medication, a diagnostic test, a follow-up. And once he or she gets to the end of that list, their job is done. There's something wrong here. It's obvious to everybody here, I know. You are not just a collection of problems. You are a whole person, hopes, dreams, aspirations, problems, resources, challenges. And when we leave the whole person out, when we break you down into a list of problems or diseases or organ systems, we've lost the most important resource that's available to us, which is what you yourself can bring to the equation. I know this is obvious, but for whatever reason, we're still working in a healthcare system that hasn't figured out how to make it the focus. So what we're trying to do in the VA is move forward this idea of whole health. We're trying to change the conversation about what the role of the healthcare system really can be. And what we're doing with whole health is taking the idea that what matters to the person is really the primary focus, going past what's the matter with you, we like to say, and talking about what matters to you. And the idea is once we can get what matters to you as a person out in front of you and your healthcare team, the possibilities are endless, really, in terms of what you can do. And we like to talk about empowering and equipping the veteran to take charge of their life, take charge of their health, and move towards what matters. That's what we're after with whole health. And it's not just that this is a nice thing to do, we like the idea. There's compelling data about why we need to do this. When people are disconnected from their sense of purpose in life, when they don't feel like they know what matters, they have 2.4 times the risk of early mortality compared to people with high purpose. And this is not just about suicide and not just about depression. This is across the range of medical conditions, cardiovascular disease, for example. For whatever physiological reason, being connected to your purpose in life leads to longer life and better quality of life. So we're aiming to make this part of the conversation that the healthcare system has with its clients, its customers, its participants. And that's what we're doing with the whole health system. we're getting some really good traction in the VA, and I'll tell you a little bit more about that. This is Jennifer Yarborough. She's an Army veteran from an Army family. Her dad was a vet, her husband's a vet. When she was in the service, she developed some injuries and some chronic pain problems, like many veterans. She got home, also developed some anxiety about the transition to home, and then on top of everything, once she was home, got a new diagnosis of cancer. So Ms. Yarborough is stuck in her house, not going out, not doing what she wants, not connected with her purpose in life. Fortunately for her, her primary care doc at the Nashville VA connected her with a health coach. The job of a whole health coach isn't to address your problems. It's not a clinical relationship or a clinical encounter. It's to talk with you about what's important to you in your life right now, and then to work with you to make a plan for how to access the tools that you need to get there. So when we talk about purpose in life, we talk about expanding the aperture, so we're really looking at the whole person. And then when we talk about accessing the tools, we talk about expanding the toolbox to get to those destinations that we want to get to in our life. So for Ms. Yarborough, when she talked with her health coach, it turned out that the thing she wanted to be doing, what mattered to her right now, was riding her motorcycle. She had been an avid motorcyclist before, but now she just felt too weak, too anxious, didn't feel comfortable going out, didn't feel she could handle it. So the two of them made a plan. She developed a workout exercise plan that she could do first in her living room, got stronger, got out to the gym, got even stronger, started a yoga class for flexibility. And fairly soon thereafter, she was able to pull her motorcycle out and ride. So why is this important? It's not just about one person or one veteran and getting back on their motorcycle. Clearly, it's about the idea that your healthcare team can help you identify what matters to you and get there. So once she's done that and gotten on that motorcycle, what's next? The sky's the limit. Might be in her work, might be education, might be being with her family. 100 different ways she can decide what matters now and how am I going to get there. And that's what we're really after with Whole Health. So we do this using the whole health system. This is a healthcare delivery model for this whole health concept. We're getting a lot of traction across VA. In fiscal year 22, we had over 1 million veterans participate in one form or another in this whole health system. 3 crucial parts. The green bubble there is called the pathway. This is where a veteran can have a conversation with a health coach or with a fellow veteran who's been trained as a peer facilitator. That conversation focuses on what matters to you. Where do you want to go? What do you want to be the focus of what you're trying to get out of your healthcare? That can happen individually, can happen in a group, can happen on the phone, online, all kinds of ways. There's no wrong door to that. But now your sense of what matters to you is front and center and available for the rest of your team to understand. Then in the lower left, where it says equip, that's what we call the well-being program. This is where you go to start to get the tools, expand the toolbox, get the skills that you need. Maybe it's a nutrition class, exercise program, yoga, tai chi, meditation. VA covers a number of the complementary integrative health approaches now. So for example, that might also be where you go for an acupuncture referral to manage your pain better so that you need less pain medication. That's the well-being program. Then there's whole health clinical care, which is where we're still treating your problems. That's still obviously front and center in our responsibilities, but it's in the context of what's important to you. And it's with the knowledge on the part of your clinical team that to get motivated to take the steps you need to get motivated to take that antihypertensive that only 40% of you take, as we heard earlier, why are you doing it? You're doing it because it helps you move towards what matters. Now, you can imagine at this part of it, convincing 100,000 conventionally trained physicians, nurses, physical therapists that they want to shift a little bit from their find it, fix it mindset and from their entirely I am the expert mindset and you are the recipient of my expertise. This is a big lift, but fortunately a lot of them went into healthcare because they wanted to be with patients and understand people and talk to them about what was important to them. So we're making good progress. This is Reverend James Mitchell, another Army veteran. He developed some foot injuries in the service, also bad sciatic and back pain. Had a smoking issue when he went in the service. When he came out, it was a lot worse. And he was in a place where similarly, he was not getting what he wanted out of his life. He was stuck at home. He was actually using a walker because of the foot pain. His breathing status was bad because of the smoking. He just wasn't doing what he wanted to be doing in his life. So he got connected to a whole health coach at the Buckley VA. The first thing they talked about, what do you want to be doing in your life right now? And he said, I want to be getting out so that I can actually contribute something back to my community and do something. I want to do something. So for him, that meant smoking cessation class with a health coach supporting him. It meant getting referred to acupuncture because the pain medications that he was on were not satisfactory to him. He was having lots of side effects. He was very unhappy with what the pain medications were doing to his quality of life. So acupuncture and yoga referrals to help reduce some of the pain so he could take less medication. A year later, he's put the walker aside. He's out. He's working as a pastor in his community and advocating for fellow veterans to access the same kind of approach. Just another example, and I could tell you literally 100 stories like that from veterans who've really been able to get unstuck from where they were using this whole health approach. And what if he hadn't accessed that approach? Well, he'd still be home, separated from his purpose, so at risk for the early mortality we talked about, probably with respiratory and other problems ahead of him from the smoking, and really looking at lots of costs, lots of unsatisfactory engagements with the healthcare system. We've seen a huge amount of success in veterans who are using opioids on a chronic basis in being able to reduce their opioid dose when they engage with the whole health system. So this is a sample, 114,000 veterans. The left-hand bar, the black bar, is veterans who did not use whole health. Over the course of this year of observation, they dropped their average daily opioid dose by 11%. So not bad. You know, we're working on everybody getting onto lower dose of opioids. Go to the right-hand side, those are veterans who engaged with 8 or more whole health visits. They dropped their dose by 38% over the course of this year. So we can't say this is necessarily cause and effect. This is an observational study, but that's a pretty large magnitude, 3.5 times the decrease in opioid utilization over the course of a year in veterans who chose to engage with whole health. We're also seeing veterans with chronic back pain who use whole health. When you look 18 months down the road from their first whole health visit, they have a 20% decrease in utilization of invasive spine procedures, so less epidurals, less back surgeries, less implantable stimulators. So not only potentially avoiding the pain and suffering of those procedures, but looking at some potential cost avoidance there as well. So just to swing back to why this is so important, connecting with what matters was what enabled both of those veterans to get out of the trap they were in, the trap caused by pain, by depression, anxiety, chronic medical illness, whatever it might be. And it set them on a road where they ultimately were potentially headed for better health outcomes. The Surgeon General came out with an amazing advisory this week on loneliness. Loneliness, the risk of chronic loneliness in terms of mortality equals the risk of 15 cigarettes a day. This is what was in the Surgeon General report. The risk of loss of purpose in life potentially is as great or even greater when you talk about 2.5 times the risk of dying. So what's the challenge? Why don't we do this? We just don't think about this as part of our job in healthcare. I take care of your diseases. I check off your problems, and that's what I do. What do you mean purpose? Why? What do you mean? And then not only that, but what if somebody tells me they have low purpose in life? What am I going to do? I don't know. How do I connect them with purpose? So we don't ask. But how can we feel good about not asking when we see the contribution that connecting with purpose can make to the kind of outcomes we're after? So there's another big challenge, and this is currently one of my big areas of obsession. How do we measure this? So, okay, as a healthcare system, we say we want to take on the well-being of the whole person. We're expanding the aperture. We're expanding the toolbox. This is great. How do we know if we're succeeding? So it turns out there are some validated measures. We're just not using them yet. There are validated measures of meaning and purpose in life, brief scales. We have a validated tool now called the well-being sign, a la Vital Signs, which asks the veteran to think about what's most important to you in your life right now, what role. Maybe it's your job, maybe it's taking care of your health, maybe it's your family. So what's most important to you right now? And then reflect over the last month, 0 to 10, are you satisfied, engaged, functioning well? and it gives you a numerical score. And so not only when we use this in clinical care does it start to change the conversation and it forces the conversation towards what matters to you, but then over time we can see whether this marker changes in response to one or another part of the whole health engagement. It's a validated scale, it moves over time. The challenge, which we're working on, is getting a massive system to change workflows to actually incorporate this in routine clinical care. But we're going there. We're going to get there. It's slow, but we're making progress. So that idea of measurement, I think, is really a big part of where we need to go in thinking about this. I have one more veteran quote. I want to read it so I get it right. This is a 37-year-old woman in getting her care at the St. Louis VA. I used to drive over the Mississippi River Bridge to Jefferson Barracks VA, think about jumping every time. The whole health system has helped me explore my purpose, find ways to use nutrition to reduce my pain, and use iRest and Tai Chi to get moving again. Now I drive over that bridge and think about tomorrow, and I have hope. And so those three words, right? I have hope. That's really sums it up. What if that became part of our mission, part of our commitment in healthcare, is helping people reconnect with that? What would that do? What would that change about patients' experience? What would it change about our experience as healthcare givers? Imagine if that is explicitly part of our job. It's both scary and potentially very rewarding and exciting. So I would challenge you to take this idea home. This is not a hard idea to get behind. I think all of you, if you think about it, you think about, would you rather be connected to what matters to you in life and equipped to get there, or would you rather not be? It's pretty easy. So would you want that for your patients? Of course. So what are you going to do? If you're a clinician, maybe you want to put in these two questions into your daily visits. What's most important to you in your life right now? What's one thing you could do to start to move towards that? Two quick questions. Maybe you could just try that out. If you run a clinic or a health system, maybe you want to think about starting routine measurement of well-being with a validated measure. You don't have to use the well-being sign. There's Cantrell's ladder. There's really quite a number of very quick, brief, validated measures of whole person well-being. Or if you're a payer, maybe you want to think about how this would enter into defining value-based care. What if value-based care included well-being? What if it included, did we really engage with what's most important to the person? That would be real value. So I hope you'll take that on. I hope you'll think about one of those challenges, and I know we'll all be the better for it as healthcare givers, and I know for sure our patients will be as well. So thank you.
Our next speaker has had such success as a physician entrepreneur that people are often surprised to find out what a tough start she had in the medical profession. The first time she took the MCATs, she got so anxious, she left. She had to take the MCAT several times for her to really show what she can do, and from there, she has grown into a remarkable healthcare leader who is here to share her ideas about AI and why, if you're not on board with AI, you might get overtaken. Please welcome Liz Kuo.
All right, great to meet everyone. My name is Dr. Liz Kuo. I'm the Chief Medical Officer of Everly Health. It's a home diagnostic company. So today, I wanted to tell you a bit more about why I'm so excited about digital health. I just flew in from Chicago this morning, and boy, are my arms tired. Just kidding. Is the mic on? Okay. Just wanted to see if you guys are awake. We just had lunch, so I just wanted to say thank you for having me. And what I also really want to talk about today is some of the great things that I'm seeing. We're in a watershed moment. ChatGPT just came out. We have these amazing blockchain opportunities with medical EMR. We're seeing a lot of remote patient monitoring. We had a great speaker earlier today talk about home care and how there's some really great opportunities for value-added work for some of really important patients. I also wanted to talk more today about some of the things that I've experienced. I myself, I still teach patients and students at Harvard Medical School. I'm a faculty there, and I just see so much change in even medical education. The other focus I wanted to mention is that I see it from not only the global side. I'm on the board of Walmart Mexico and Central America, where we're doing retail work in virtual care, home pharmacy, but we're also seeing all this great work within the space of home management and modern diagnostic care. The next speaker after me will also talk about how digital health is changing a lot of lives. But I did want to mention some things that have maybe started with me being an MD, but having some own, not only personal challenges with the MCAT, thank you very much for highlighting that. I definitely struggled, and I'm very grateful I got through medical school. At the same time, I also had some issues. So I'm a physician, but a couple years ago, I was pregnant with my first. And after a couple of days I was expecting, we had the nursery all done, and I just had a little bit of a headache. I had some symptoms. They weren't really severe, so I sort of brushed it off. The next day I went to the ER because I didn't feel as much movement, and the baby died. So I was 9 months pregnant, and I lost the baby. I think through this day, because I talk about digital health in a way that I think can help a lot of people scale what they're concerned about. Home testing is one thing that I really get passionate about, but it's also remote patient monitoring and the ways that we can scale provider shortages, allow people to kind of know what their symptoms are and trace it and track it. I think to myself, if I had those symptoms, but I actually tracked it, maybe had a pattern, I could develop a recognition for what I was experiencing, I could have put 2 and 2 together and understood that maybe there was something wrong, that this baby isn't moving as much as it should have. I will also fast track to say I'm very lucky. I do have 3 wonderful children now. But at the time, it really motivated me to think about how do we use digital tools? So how do we stay at the intersection of medicine, technology, and then business? When you understand these 3 kind of stakeholders, how they think, how they practice, what are digital tools, how are they practical, and then on top of that, what makes business sense? How do you get these key stakeholders, which I often talk about, which is the 3 Ps, but on top of that, 2 more Ps, 3 Ps. Payers, patients, providers, but also policymakers, NCQA, FDA, and also pioneers. The last 2 are the key things. Pioneers push innovation ahead. A lot of this book that I'm putting out together right now is this idea of how do you get pioneers and policymakers to think through. There's sometimes a little bit of tension, right? Innovators are always kind of pushing the envelope, but policymakers are also trying to figure out, hey, scale back a little bit, let's think through how this is quality improvements that are important for our society. Actually, funny enough, my husband always jokes, I'm putting this book together called Digital MD, but I also have sometimes issues with uploading PDFs. So that's another story for another day. But here I'll talk about some of these better decisions for better health. I really believe that we can think through how to engage the patient for where they are. I oftentimes sort of do interchanging words of patients versus consumers, but I actually think it's good to call them sometimes consumers. Why? People don't want to feel like they're a patient. They don't want to think that they have chronic disease. They don't want to be labeled as that. So I think through how do we engage patients or consumers where they are. What we do at Everly is we do home testing, but an important thing is I actually think we can do tests to engage, to transform the way they think about care to treating. There's this concept where wellness is a journey, as we talked about earlier with Ben. There's a journey of healthcare, and how do the people want to feel? They want to feel excited. So even, for example, the company I work for, Everly Health, we do a lot of focus on wine and cheese parties where people actually sit together and do testing. So they're not worried about their health. They're actually trying to engage. They're trying to empower themselves to figure out what food sensitivities do I have, and then ultimately make informed decisions. I also think it needs to be medically guided, right? It shouldn't be, the quality has to be true and correct. But if you meet people where they are, which is the first part of this talk, then you can really get them excited about about any kind of care. So testing is one thing, engaging, and then transforming and treating. Last thing I'll mention on this slide is that 70% of diagnoses come from lab testing. We know that helps a lot. What we're seeing right now is virtual care is kind of bread and butter. It's everywhere. But if you don't have the right biometrics or the right stats or the right information, even as a provider, I can't tell from a virtual consult what this person needs. They may give me some symptoms, but I don't know if they have diabetes. I don't know if they have A1C issues. I don't know if they have cholesterol, high cholesterol, blood pressure. So all the vital metrics and biometrics are really key to getting us to the next stage of what virtual care can do. A lot of things we also see about healthcare consumers is that they prioritize what we see on the left-hand side. So the ownership of their healthcare data, this is what consumers want. They think about transferable information, both if they do some testing here, they want to make sure that their PCP sees it. If they don't have a PCP, when they enter into a hospital room, they want to basically have some of the former data that they had. There's also personalized care, so healthcare services that are really serving individual needs. We're seeing that now with precision genomics and all these great things that are happening, but how do you make sure that that information is really insightful? What I also talk about is oftentimes this idea of the 4 Ps. So being insightful is one thing, but is it prescriptive? So you can get this information, but does it change either personal utility? Does it give you change in how your behavior is going to be? And or does it help a physician say, okay, you got this test, you do have diabetes, let's get you onto something else. So one thing is P, prescriptive. The other thing is personalized, so making sure that it's the right kind of care for this person. Another thing is predictive. We're seeing, as we heard about earlier, there's now a lot of AI and work that's getting people predicting acute kidney injury, chronic care, and other things, so predicting things. And the last thing is preventive. I really believe that if we think through things about what we can even do right now, for example, with Everly, we're looking at testing for chronic care, kidney disease. So if you are able to get, let's say, testing for stage 1, you know that you have stage 1 chronic kidney disease. You want to make sure that it doesn't progress. And you can, if you're able to track it and measure it over time, it's very key. Also, we talked about seamless and efficient end-to-end journeys earlier in another speaker too, to make sure that it's intuitively and digitally enabled, and there's greater access to choice. Affordability and transparency has been an issue in our country, as we know, because sometimes you walk into a hospital, you don't know what the hospital bill is going to be. The issue with that is that you can go into a Walgreens or a Walmart or buy a purse and you know the price. Here we don't. So being able to say, this is a transparent price point, we're giving it to you, we know what you're going to get, and you're not going to have to pay anything more or less. What I see on the right-hand side is how digital can deliver. When we're thinking about personal health records, you know that you can own your records and by the consumer. Analytics-driven AI work is something that's starting to happen across the VA and other areas. Even with DeepMinds, they're actually testing for acute kidney injury. We're also seeing some great work with even research where something very similar to driverless cars, convolutional neural networks they're allowing researchers to actually map out protein binding to small molecules and being able to do drug discovery. There's so much going on, and it's such a great time. There's also interoperable data, which is a key thing. When I was at Anthem Elevance, we were doing prior authorization that was automated. So being able to say, reach into medical records, pull out what you need, and send this to the physician and say, you can authorize this MRI in real time, that's the future of where we're headed. So being able to get data, authorize it, and having interoperable is really key. And the last few things are integrated insurance platforms is something I'm very passionate about coming from there. And then a simple provider search or transparent pricing. Now that I've talked a bit about this area of how we're thinking about digital health, I'd like to talk about some of the ways that you can meet patients where they are, in the rooms, in the houses, in their homes. US consumers can be classified into a few key areas. This is where, when we work at Everly, we think through a lot of what consumers want. Where can you meet them, where they are for the things that they want at the time that they need it? So I'll talk through about a few more minutes on this. So it's basically the 5 different personalities we see when consumers are purchasing, buying, utilizing healthcare. If we can really grasp this, I think this can sort of change the dialogue about wellness and the healthcare journey, rather than, oh my gosh, now I have to take this test or get this colonoscopy. So we see self-achievers. These are people that take directions, but they also really know how to take charge. They're task-oriented, they want to get things done. They're focused on moving into the next phase of their life, and they sort of plan ahead. We also see balance seekers. These tend to be people that are always asking why. They're balancing a few different things in their lives, and they're asking, why do we have to do this? What's the reason? And they try to figure out, does it list out in my priorities of things, my career, my life, my children, my family, and other things. There's the priority jugglers. These tend to be sort of the family stakeholder. They're creating the ecosystem within their family. They usually give up a lot to not really care about their own health. They're usually moms at home trying to figure out how to help with their family. So they care about everyone else, not so much themselves. So but they're juggling all of the priorities around the home. And then these are direction takers. These tend to be people that really believe on authority. So if it's a physician or if it's a provider, they'll take that. And then they just want to know, give me what I need to do. And then last thing, this was me, a willful endurer. Those are majority, or not majority, but a bigger part of the population that tends to kind of put wellness to the side. They don't want to get screening. They're a little bit tired. They're the ones that are harder to engage. But the ones that we've seen are, if you get them interested through whether it's social channels, things that we talked about earlier with even TikTok or Facebook or Instagram, I really believe we can start to get people's attention. To make sure that testing isn't scary, the results that you get back don't have to be scary, that you can have someone holding you through that. So the last few slides I'll mention here is just, what do I challenge you with? When you're thinking back about this talk, I hope that you can think through some of the 4 Ps and the 5 Ps, but some of the other things are areas of, we're in a watershed moment. This is key. If you don't think about anything else, it's that the world is changing very much so. And consumers want data, they want ownership, they want price transparency, and they want usable, accessible care. There's a consumer-driven healthcare model that's starting to take off. We're seeing that across all of the ecosystem. So meeting them where they are when they need it. The other thing is digital health must enable a return on the investment through lower costs for payers and patients. So thinking through, how do you make digital health accessible, easy to use, but also helping the provider save time, the payers also driving down some healthcare unnecessary waste or use, and also making sure that it's understandable for the patient and it drives cost low for them. And then last thing I just challenge everyone to try is ChatGPT. It takes about 1 minute of your time to answer anything that you want them to answer. So I would recommend just going onto it, typing it into your web browser, because I do think it's time. This is here. I'm seeing it a lot across the board with people using it for all sorts of things, even writing recommendation letters. So it's the time to try to get on board, adapt to what we're seeing, and I'm looking forward to hearing more from the group. So if you have any questions, let me know. And this, I'll say, these are my 3 kids. I'm very thankful after all of the journeys that I've had. So I hope you enjoyed the talk. Thank you.
We have been honored over the years to meet and host at Quality Talks many remarkable and accomplished people. I hope you've seen today that trend has continued. However, we've never had an Olympian on stage until now. The focus and energy that our last speaker used to propel her to the 2008 Beijing Games, where she represented the United States in rowing, she applies that energy and drive now in helping healthcare leaders understand and appreciate the possibilities of digital medicine. Please welcome Jennifer Goldsack.
Well, this is a bit disappointing. After an introduction like that, I want to be able to leap onto the stage, but unfortunately here I am hobbling in. Hi there, Jen Goldsack. I'm the CEO of the Digital Medicine Society, or DIME. I'm going to start with our mission. So our mission is to advance the ethical, effective, equitable, and safe use of digital technologies to redefine healthcare and improve lives. But outside of healthcare, just thinking more broadly about society, one of the things that I've been reflecting on a lot recently is how fragile an ecosystem we find ourselves in. We've lost a lot of faith in science. We've largely lost trust in clinicians, and we've lost trust in government. This is a challenging time for us to be engaging in medicine. And the healthcare system itself is also fragile. This system that was designed to care for people, or intended, perhaps is the right word. This system that was intended to care for people, this system that is struggling terribly with access and equity, and the mental health and the longevity of those individuals that we depend on, those clinicians, to actually care for us. So there's sort of an obvious way I could take this now, which is to start railing on the US healthcare system, right? This system that, costs twice as much as anywhere else on the face of the planet, and where the outcomes are the worst in the developed world. That would be easy, and that would be lazy. And I think it's much more nuanced than that. And I think we have to sit with that nuance for just a moment to be able to make forward progress. And, I'm happy to reflect on my own sort of recent injury rehab journey, because I think that reminds us that it's not the worst healthcare system in the world, and that's a sort of silly statement to make. I had surgery at the Hospital for Special Surgeries right at the end of January. I had all sorts of knee difficulties that was a legacy of having absolutely no sense of moderation in how I treated my body for several decades, so it does come back for you. And under any other circumstances, I would have been, and I'm about to tell you a big secret, I'm 40. I would have been 40 with a knee replacement, and then I probably would have had 3 or 4 during my lifetime with a pretty crappy, that's the technical term, quality of life. But for a number of reasons, I had access to extraordinary other options. First of all, I was health literate enough to know that a knee replacement surgery would be a pretty terrible option for me. I have, thanks to my husband, really tremendous healthcare. I have a network of people that I could draw on, folks from my time as an athlete and also my professional career where I could talk to people, where will I find the most rock star knee surgeon that you will ever set your eyes on? I had the ability to travel. I live in Florida, so to go out of state for surgery means that you don't just go there for the day, you have to be able to stay for a number of days afterwards until it's safe to travel. My husband's in the military, he was on active duty, and so I had a support network. I had friends who could come and stay with me in a hotel just around the corner that I could afford while I recovered before traveling home. So I was spared a knee replacement, and in fact, the surgeon did say, well, I will probably never need one due to things like cartilage grafts and de novo cartilage and, the breaking and realignment of joints so that now the places where I had terrible arthritis, for example, are no longer points of risk. That's extraordinary medical care. That's extraordinary science. So it's not that we have a terrible healthcare system. It's just, it's so limited to the privileged few. And I was so very lucky, not just to be able to access that, but to work a knowledge job where I could quite literally lie in bed all day, like Lady Muck, and take my calls. And I, after 2 or 3 days, and I should have probably taken a few more. I don't think I was at my best on all those drugs my first day back. But, I was able really not to skip a beat. What an extraordinary privilege. There's other things we could think of too. So, as you might be able to tell, despite being a US citizen, I didn't grow up here, so I'm familiar with very different sorts of healthcare systems. And the reality is that healthcare systems around the world are struggling. There is no perfect healthcare system. There is nowhere that's doing it perfectly well, and if there was, we'd all be doing it. I can look at the NHS in the UK, and I can look at how they're struggling with the burden of chronic disease. I can look at the mass exodus of clinicians that they are also experiencing and enduring. I can look at the unsustainable costs of healthcare, even in a fundamentally different system. So we are in a moment of crisis when it comes to this idea of how do we create a system that can effectively meet the health and healthcare needs of individuals in this day and age. So I'm the digital person, right? So I'm going to tell you it's AI. Maybe. But actually, what I think we need to do in the digital era of industry, and hopefully finally the digital era of health, is think less about tools and widgets and algorithms as silver bullets. And we need to think more of digital tools in the toolbox as enablers. Great. So enablers of what? There's a turn of phrase I like, which is, if you don't know where you're going, anywhere will get you there. So when we are talking about these new digital tools, these algorithms, these flows of data, what are we actually trying to do here? What are we driving towards? What does good look like? Well, not shy, so I'll share my opinion with you. This is what I think we should be driving towards. I think we should be driving towards a healthcare system that is built around the patient and not the clinic. I think that we should be driving towards a system that isn't sick care, but that's health care. Okay, great, those are 2 really good bumper stickers. What do I actually mean? So let's think about what we actually do in reality vis-a-vis healthcare today. Our clinicians sit within the brick and mortar walls of a hospital or a clinic and they wait. They wait for patients to turn up sick, knock on the door, and request an appointment. Sometimes due to access issues and a variety of other issues, by the time that patient arrives sick on your doorstep, if you're a clinician, that person is much more sick and frankly much more expensive than they could have been under other circumstances. And so what I envisage in this digital era of healthcare is reimagining this this entire system so that we are truly a healthcare system, so that we can actually use some of the things that I think characterize the digital era of healthcare, flows of data, right? So it's no longer that we're restricted to clinical data collected within the walls of the clinic that we store in a manila folder in a file cabinet and only the practice manager has a key. Rather, we can generate all sorts of data in the clinic, a plethora of data outside of the clinic, some of that data that's much more important to your health and healthcare and future health risk. And we can also, many people can access that data, as I said. It's not locked in this file cabinet anymore, and we now have the computational power to be able to analyze these data. This opens the door to the learning healthcare system that we've been talking about for decades and yet haven't been able to deliver. This opens the door to a fundamentally different way of caring for people, where we are trying to think about good healthcare not as how good we are when you turn up at the clinic, but how good are we at keeping you out of it? How can we think about, first of all, identifying sooner that you may be at risk and intervening sooner? How can we make it so once you have perhaps a chronic condition, we manage it in a way where your quality of life is much better, and good looks like keeping you out of the clinic unless you need those particular screenings, those particular moments with a specialist clinician, the ones that really are only essential because we are keeping you well, and that is good healthcare, instead of doing a patch-up job once you get sick. So I talked about flows of data. I talked about our ability to run analyses on this data to allow us to not only do precision medicine, but precision prevention. Prevention. This is what I think is really exciting. But there are other elements that we require and that digital actually provides too. We can overcome the maldistribution of specialists, for example, and the patients who need them, because through a variety of different communication technologies, we can overcome the challenge of space and place. We can also think about our ability to use other tools that perhaps aren't digital, right? We can layer in some of the home diagnostics that we were talking about. We can use more local members of the care team. And I think it's really, really important too that we don't just assume that we are going to tech our way out of this, right? The tech is the bottom of the stack. And then we have your traditional clinician team members, but we have new members of the care team. So we need to think about things like health coaches, peer support, and those can be either accessible digitally or they can be in your local community. We were hearing from Ben earlier about the importance of things like purpose and the risk of loneliness. We can overcome that by engaging people in the local community in true healthcare, not just clinical sick care. These are the opportunities we are offered in this day and age. This is what it means to use tools like virtual first care, which, by the way, is not virtual only care. The reality is no one can ever receive all of their healthcare in the ether. We are going to need to come in for procedures occasionally. We are going to need to be face-to-face occasionally. We are going to need, surgical interventions occasionally. But how can we reimagine virtual first care that is virtual until it isn't preferred, until it isn't safe, until it isn't effective? These are the questions we need to answer ourselves. And for folks who may think, is this really the way that we want to go with our healthcare system? I challenge you with some statistics as we sort of finish, which is 50% of counties in the United States today have absolutely no mental behavioral health capabilities whatsoever. And we find ourselves in a mental health crisis. So absent these sorts of approaches, what is the plan? Similarly, mental health needs are not 8 till 4, Monday to Friday. They are 24/7, and we need approaches to be able to overcome those limitations. This is where virtual first care becomes powerful. We can also think about the fact that 1 in 3 Black Americans live in counties that have absolutely no heart specialists practicing in that county. How will we care for them if we don't embrace these approaches? We can think about the fact that the rate of bankruptcy among cancer survivors is 2.5 times that the rest of the population because of the financial toxicity that comes with the way we care for people with cancer today that requires you to go to a center of excellence if you want that best chance of survival. And we can think about the fact that young women, young Black women, are twice as likely to get breast cancer as women of other races, and they are 3 times more likely to die. It's not enough just to think about layering in digital approaches, sprinkling it in, and just using it to improve the current system of care we have. We have to create a different system. We have to create a system that actually cares for people, and we have to create a system whereby we measure good quality care by how good we are at keeping you healthy and how good we are at keeping you out of the clinic, not how good we are at intervening once you present already sick on the doorstep. So I challenge you not just to be open-minded about the digitization of healthcare, but to think about what it is we're actually trying to do here. And as I said, I'd advocate for a reimagination of the definition of healthcare in the United States. And I think we need to rally around this definition to be effective. So thank you so much. It was a pleasure to be here and look forward to conversations later.
Wow. Don't you agree? I have to congratulate Andy and our team that helped put this together. And I want to just really recognize the brilliance of the talks that we heard today. And there are some themes that came through. I think one of them is that we've designed a healthcare system for the system, not for the patients. And that the digitalization and the kind of uncovering of data in real time from patients really will allow us to transform this thing into something that will be unrecognizable in the best possible way in the future. I think the other thing is the sense of excitement as people are learning as they go. And I think that's one of the things that's really changing here. Healthcare has been a pretty stodgy enterprise. And I think those days are over. And I really want to thank the pioneers that are pointing the way to the future. And we look forward to the challenge of trying to get this more widely adopted. It feels daunting to kind of really contemplate the degree of change that we're all facing. And I think by working together, by remembering that we're about serving patients and improving the health of Americans, we will get there. So right now, you have an opportunity to go hear more from the last 4 brilliant speakers. And then I encourage you to stay for the reception, which starts at 3:45. So thank you so much for being here. Thank you to the people on the phone for your kind attention. We're sorry you can't be here to have a glass of wine with us. But please go forward and go to the breakout sessions, the salons. And thank you for everything.
Quality Talks is brought to you by several generous organizations. NCQA thanks Platinum sponsor Merck for an independent educational grant to support this event.
Welcome back to the live stream here at Quality Talks. I'm Dr. Nick, leading you through the interviews, inside scoops, and all things quality. All day today on the stage, you've heard from luminaries with something new and different to say about healthcare in the United States. We're back here at the set to meet a few more voices in healthcare, including a close-up chat with Dr. Aaron Neinstein and Dr. Anita Ravi. But first up, healthcare leader, NCQA executive, Dr. Bryan Buckley. Dr. Bryan Buckley is a director of the Health Equity Initiatives at NCQA, the first to hold this position. Dr. Buckley, welcome to the show.
Thank you for having me here.
So if you would, give us an overview to the NCQA's health equity approach.
Yeah, so one, I would like to always start that this is a journey, and we're doing it in collaboration with others within the community. And so I like to think of our approach in like a 4P framework. One, making sure that we're hearing from many different perspectives, making sure that we're talking to people on the front line, making sure that we're talking to community members, public health, payers, healthcare delivery. But then also thinking about the process, thinking about our products and services that help to optimize the process for the organizations that we work with. And then remembering, and I think it came up in quality talks quite a lot, around people, thinking about the emotional impact that inequities are having on communities and making sure that we're keeping that at the center of everything that we do. And last, I always say projection. What's the story we want to tell of ourselves for the future, but what's the story people are going to tell about us on how we try to drive health equity moving forward?
So, new role, new position. Tell us how things have been going.
Yeah, new role. It's been going. I like to say my first couple of months, it was on the Gemba walk journey, listening and seeing. Listening not just to the folks internally on what they've been doing and hearing about a lot of the awesome work that our team is doing. I often say we have like a Justice League here at NCQA, but then also going outside and talking to our customers, talking to the people that work with us to see what are the innovative things that they're doing in their role. And so it's been pretty good. And the whole key is listening, reflecting, and framing with an eye towards action.
So what are the goals here with incorporating equity into our work?
Well, one, we're going back to the tenets of what is high-quality healthcare. Equity has always been one of the domains of high-quality healthcare ever since Crossing the Quality Chasm that came out in 2003. So when we talk about embedding equity into everything we do, it is taking a review, an audit to say, okay, where do we see that there are inequities? And the knowledge has been changing rapidly over the past couple of years to making sure that we are keeping up with the industry and helping them advance to a more equitable and just society, and making sure that all of the patients not just have access, but access at where they are at.
So tell us about some of the leaders that you've seen and you've interacted with and perhaps some successes.
Yeah, so we have been talking to so many leaders. Being in this inaugural role for health equity, I'm meeting health equity leaders, whether it's in the internal DEI space, whether it's more external health equity, and also our community members as well. And so one of the great groups I get to be part of is the Rise to Health Coalition, which is working with several healthcare stakeholders across the healthcare continuum. So IHI, AMA, AHIP, Race Forward, so many others that are constantly joining this coalition because we realize that health equity is a team sport. And so that's the important thing I want people to remember. It's a team sport, so you can't do it alone. You have to do it in collaboration with others. And so I'm getting the opportunity, and one of the things as health equity leaders that we're doing is making sure that we take the time to talk to each other and learn from each other so we don't have to make the same mistakes. I also get the opportunity to teach also at Georgetown. I often tell my students, the cost of life tuition is really high. And so we have to take the scholarships of the words of wisdoms and the lessons learned that people have had before us. And so I get to be super blessed that I have a full ride through this journey because I get to talk to all of my health equity peeps that can share their life lessons and their journeys along how do we actually try to make this stick and make sure we advance the movement.
So it strikes me, I like that concept of, that ride through and the supporting environment of the team approach. How do we amplify that? How do we make that more common, more part of the general experience that people have and contribute to in healthcare?
One, I think it starts with having conversations, and that's a big part of my role. How do we meet people where they're at? When it comes to building an equity into everything you do, it's not easy. It's a paradigm shift of how we have thought about healthcare for the past several decades. And so it requires patience, but then also understanding. And for many folks, it's understanding the lexicon of how do we talk about health equity, because it's something that's always been around, but not everyone feels comfortably saying everything. So one of my rules that I look at is trying to provide a space for psychological safety for leaders to talk about, hey, these are the challenges I have, and not just to frame it into the return on investment, but understanding the moral and community case for why we need to advance this work.
In the closing seconds, tell us what advice do you have for companies and organizations to bring this into the full feature in their organizations?
That's a good question. So I'm going to take one of the mantras that I have, being Bryan Buckley, and B is this whole idea of be hungry, be curious, and be humble. Be hungry to know that we need to drive and really be obsessed with trying to eradicate inequities within our communities. Be curious to know that there's many different pathways to get there, and be humble to know that you cannot do it alone. You need to work with your community-based partners, your community partners, and so many others. It's a team sport to really making a more equitable and just society. So,
and B. Bryan, thanks for joining me today.
Thank you.
This year, Quality Talks is proud to welcome Dr. Garth Graham. He's the Global Head of Healthcare and Public Health at Google YouTube and YouTube Health. His unique perspective on social determinants and health equity bring the entire healthcare world into focus. Hear a bit of Dr. Graham featured in episode 104 of NCQA's podcast, Inside Healthcare.
Across the world, I would say this concept of determinants of health is very real. It is the same in Sao Paulo as it is in the Bronx, as it is in Kyoto, Japan. I mean, all of these concepts feed into health outcomes, and that's where information plays an important role. What's different is, again, the cultural nuances and the way people approach healthcare. But in many ways, the challenges point back to this idea of how do you get and engage people in genuine personalized healthcare.
Check out our Inside Healthcare podcast, available at blog.ncqa.org or from any Apple or Google streaming services. As we've said, NCQA is about quality in healthcare. We want to make healthcare better for everyone throughout the United States. Take a look. For more about NCQA's programs, education and training, go to ncqa.org. We have over 20 sponsors for this year's Quality Talks event. One of our newest is Scene Health. Our next guest started out as a lawyer in England before launching his first company in Munich over 20 years ago. Sebastian Seiguer is the CEO and co-founder of Scene Health, formerly known as eMocha. Scene Health deals with improving medication management. They combine telehealth methods with clinical coaching, developing new methods of patient intervention. Sebastian, welcome to Quality Talks.
Thank you for having me.
So if you would, tell us what medication non-adherence is. And I think you use that term very specifically as opposed to non-compliance, right?
Yes, compliance is probably a word used mostly in clinical trials. So non-adherence refers to patients not taking medication as prescribed. So on an actual day, was medication taken properly? Was the technique, administration correct? And are they taking it over a period of time consistently? So that's very different than the quality metrics that we're talking about today. The adherence quality metrics are really a proxy. That's really a refill measure.
So it's very clear, based on some of the talks that we've heard through today, that the compliance is actually relatively poor. What are the costs to the healthcare system as a result of this?
Look, when people don't take their medication properly, they end up in the hospital. It's very simple. This has been documented over decades. The cost of non-adherence to the entire healthcare system is well over $500 billion a year. That's even more than we spend on medications themselves. But it's also very obvious. Medication regimens are more and more complex. People are leaving the hospital and spending less and less time in front of clinicians. They're confused. Medications are complicated, so it's not a surprise that people are ending up with issues with their medication and ending up in the hospital.
So I've got to say, as a clinician, that's got to, for me, very frustrating. You know, you prescribe, it's not happening. So how do you go about using science and metrics to improve on this?
Right. Well, in terms of science, you're very right. So the physician's orders, our job at Scene Health is to enforce those orders. Enforcement's really the wrong word here, but fact of the matter is, over the last decades, there's only been one method documented, when we're talking about science, in peer-reviewed literature that shows a measurable increase in medication adherence. And that is a process called directly observed therapy. So every dose of medication in the inpatient setting, no exceptions, every patient, all conditions, they're all observed. Your therapeutic effect is measured, understood. Outpatient setting, it all falls apart. So in terms of using science, we lean on the model of care, directly observed therapy. We enhance it with video. And ensure the same result that happens inpatient, that gold standard of adherence, we're bringing it to the outpatient setting.
So as I think about this isn't just the patient. I mean, this is a community affair with family members getting involved. For those that are suddenly finding themselves in the caregiver situation, how do you shift the responsibility from the patient to themselves, to the caregiver?
Well, you can't entirely shift the responsibility here entirely to the caregiver, because the patient has some accountability here as well. But the fact of the matter is that the regimens can be very, very complicated, and it would be totally normal to have a great deal of confusion around medication. What a caregiver can do is help eliminate that confusion. Make sure that questions that come up are answered by the provider. So a caregiver can play a really big role in helping navigate what is, in this country, an extremely complex healthcare system, and allowing the patient to have clarity as to what exactly they should be doing. And if they don't understand that as a caregiver, get the answer to the question.
So in the closing seconds, what would you advise for organizations that are thinking about this, for physicians? How do they sort of enable this to get the best results?
Well, I think that for physicians and for practitioners in our healthcare system, they're very overwhelmed. And I don't think that having them do one more thing is the answer to the question here. I really think that from the health plan side of things, where health plans are accountable for the care they're delivering, for the costs, health plans can move to a measurement of adherence based on whether people actually took medication and not whether it landed in their mailbox. Right, so take accountability for whether people actually take medication properly.
I think that's a great point to finish on. Sebastian, thanks for joining me today.
Thank you so much for having me. Take care.
Just a reminder to use social media to connect with other Quality Talks viewers and discuss what you're hearing today. Comment on it, comment on the speakers. Do you agree with them? Maybe you don't. If you don't, let us know. Here's another thought question for you. What's your biggest hurdle that your company is facing in the digitalization of your healthcare workflows? Tell us what you think. Follow us at NCQA on both LinkedIn and Twitter. Use the event hashtag QualityTalks2023. And now I'm excited to welcome Dr. Aaron Neinstein. He is the Vice President of Digital Health at UCSF Health. He's an associate professor in the Division of Endocrinology and the Senior Director at the Center for Digital Health Innovation, also known as CDHI. He works in CDHI to improve telehealth and remote monitoring technologies. Dr. Neinstein is an expert in digitalization. Hopefully, he can tell us how far we have go to get towards the digital health utopia that we're all looking for. Dr. Neinstein, welcome to Quality Talks.
Thank you so much, Dr. Nick. Great to see you.
So let's start by defining some of the terms. And we hear these two counterposed, digitization and digitalization. What's the difference? Tell us.
So the really surprising thing is that when we talk about digital transformations, people often focus on the word digital. And the surprising thing is that transformation is actually not about the technology. It's about the cultural changes within an organization that are enabled by technology. So when we went from paper records to electronic health records, we achieved digitization. And I would say in most places right now, we're in the stage of digitalization, which is moving to new products and services and experiences that are enabled by having this technology. So that could be things like a remote monitoring capability or allowing patients to self-schedule. But what transformation really is about the cultural change and the ability to quickly iterate using learnings from customer, or in this case, patient data, to help you generate learnings about the patient experience and to make it better, and to be running rapid experiments within the organization on how to make that better and better over time. So a common analogy I use is the difference between Sears and Amazon. So everybody knows the story there, right? So Sears created a website where they sold consumer products through the internet. Remember this, right? They did not miss the boat on that. But what Amazon did differently is they realized that it wasn't just about the website and selling products to the internet. It was about creating a technology infrastructure that allowed them to capture granular data about the end-to-end experience of their customers, and to have teams and a culture in the organization to use those data to make the experience better and better over time. And that's what transformation is.
So as you think about it, I mean, we're making progress, but not as much as we would like to see. What are the barriers that you've seen, and how do we overcome them?
So the good news is we've just gone through digitization, and so it is still early. The barriers are that most healthcare organizations are large and very traditional, and culture change in any direction takes time. And so the biggest barriers really are that this is the hard work of doing cultural transformation within an organization, changing the way that people approach their jobs, their mindsets. It requires bringing new types of expertise into organizations. It's not typical for healthcare organizations to have designers or data scientists. So you're bringing new types of expertise into the organization. It requires creating more standard workflows operationally so that you can actually collect data to learn from. And in many cases in healthcare, we still have very custom bespoke workflows in many places. It requires creating a data infrastructure to collect data into one place and to use it to generate those insights and learnings. So there are a lot of elements of really organizational infrastructure, expertise, data, technology platforms, culture that are required to make this work. And when in most cases in American healthcare, when we deployed electronic health records, we put technology on top of existing organizations, and we haven't yet done the work of transforming what's below the surface.
So go back far enough, informatics wasn't even a word, I don't think. Now it's even a board-certified specialty, critical component. How does informatics become part of this solution and get engaged? What are the elements to that?
So informatics is a field that really combines having a clinical practice, whether that's medicine or nursing or pharmacy or some other clinical practice, and combines data, software engineering, information science, design. And so the work that we have ahead is really understanding the needs of our patients and of our providers, whether that's nurses, physicians, or other clinicians in the healthcare environment, building workflows that allow us to collect data and insights and to improve those experiences. So informatics as a field was really built for exactly this moment, which is we have now moved from paper to digital records, but we now really need to drive data-driven insights and learning from having achieved digitization.
So I think overall, exciting times. I think digitalization and the digital innovation that we're seeing in healthcare is extremely important, delivering fantastic benefits, but there's a lot of work to do. Team sport. Dr. Neinstein, thanks for joining me.
Thank you so much. Really appreciate it.
Dr. Aaron Neinstein was once your office to undergo a digital transformation. But is that right for everyone? What about data corruption and identity theft? How does digitalization make things better instead of worse? Hear a bit of episode 104 of NCQA's podcast, Inside Healthcare.
From different languages to different levels of education, to different cultural backgrounds, to different accessibility needs and requirements, people with either hearing impairments or visual impairments. Technology can help us advance health equity and deliver care in the way that people need, rather than one size fits all.
Check out our Inside Healthcare podcast, available at blog.ncqa.org and from any Apple or Google streaming service. As we head towards the finish line of Quality Talks 2023, we look ahead to our big event in the fall, the Health Innovation Summit. Healthcare leaders and tech experts, training and educational sessions, and an exhibit floor showcasing the latest in innovation. All these await you at our summit. Watch this. We hope you're as excited as we are for the summer. This year, we're in Orlando at the Gaylord Palms Resort and Convention Center, October 23rd through 25th. You'll get 3 days to meet and hear from healthcare leaders from around the country. Registration is open right now. For more, go to ncqasummit.com. NCQA has been hosting Quality Talks since 2015. Compared to every conference you've experienced, Quality Talks is deliberately different. Quality Talks encourages us to think about what's new, what's next, what's possible. Here's a look back at some of the past presenters at NCQA's Quality Talks.
If you are a caregiver, you are twice as likely to have depression. You are twice as likely to be coming down with a chronic condition. You're actually shortening your telomeres. And that is a how long you're going to live kind of problem. If you're over 66 and caring for an aging spouse, you have a 63% higher risk of mortality. So whether we're talking about caregiver stress, financial stress, relationship stress, or workplace stress, the reality is these life challenges are diseases in their own right. And they deserve a seat at the adult table.
We have to get real, though. It's what worries me about this is monopolistic practices are well known to raise prices, not reduce them. We're already seeing this through hospital mega mergers that have been taking place for years. And it used to be if you're a player in healthcare and you figured out how to reduce costs, you reduce somebody else's profit, right? But now it's rapidly changing to a world where if you reduce costs, you're increasing your own profit. But you could share that with consumers, but that's no fun, is it? So I think that's the crux of the debate right there. Are we really doing something that makes a good difference?
Life is a difficult journey, but working together, we can make something really good of it if we do these 3 things. Dare greatly as members of fabulous teams. Tell the collective truth about the journey along the way. And last and most importantly, reaffirm one another in that journey through good times and bad.
Hi, everyone. Time for another visit with one of our incredible Quality Talks 2023 speakers. Dr. Anita Ravi is CEO and co-founder of Purple Health Foundation. Purple is a non-profit that addresses the comprehensive health of survivors of gender-based violence through a novel model of clinical care, research, and education. Dr. Ravi is board certified in family medicine. She's a physician who specializes in health of gender-based violence survivors. She regularly writes and speaks at events across the country about how the healthcare system must radically change to meet the needs of survivors. Anita, welcome to Quality Talks.
Thanks. So nice to be here.
So, Purple Health, I've got to say, I've got a question.
Sure.
Why Purple Health?
Sure. So people always ask if the spelling, it's the capitalization, like what's the story about that? And it's very purposeful, actually. Purple stands for purpose, listen, and engage. And so the L and the E are capitalized. And that's really how I think about healthcare. We take the time to listen, and then we engage instead of doing things to people. So, yeah.
Fantastic. I like purple and favorite color, so
Great.
That's a good thing.
That's a win.
So how do you put all of the research into action?
That's a great question. So I think a lot of it is, it's the circular model where you're doing care and you're learning in real time. This works, this didn't. Why didn't this patient come back after a visit? You start to collect data, you publish it, and then when you publish it, you have the opportunity to teach it to more people. And from the teaching is where you learn other ways to do it. And then we try it again in the clinic, and it's a fulfilling cycle where you just get better each time. So that's
So
how it does
constant
it.
improvement all the time, right?
Yes, exactly.
So how do you get this to the clinicians, to the people at the coalface who are essentially struggling with this? I mean, even struggling to recognize some of this. What's your advice to them?
Yeah, so I think one of the most important parts about the work we do, it's not just the clinical care with patients, but it's also all of the training that comes afterwards. So we get a lot of invitations to give talks to healthcare systems. Sometimes it's this comprehensive thing where front desk staff will attend. It's all the clinician, the front desk staff, the coding biller person, because there's ways to do trauma-informed care approaches that are really patient-centered and system-centered. And you have a chance to scale what you see in a small practice into different healthcare systems. So I think a lot of people reach out because they feel the pain points when they're doing the work, and they're looking for ways to make it better.
So I know you have a foundation, you have a clinic. It feels to me like this is a little bit of, eating your own dog food, putting things into practice. Well, what's the difference between those two?
Yeah, so the Purple Health Foundation fully funds our practice, which is called Purple Family Health. And Purple Family Health is an affiliated clinic. It's kept at arm's length from the foundation. But that is the way that we're able to do care without taking insurance and making sure that, again, we can center patients beyond metrics that other stakeholders demand of patients' information.
So I know you actually service clients at Rikers Island, the incarcerated. That's probably a very challenging activity as part of it. What can you tell us about that?
So yeah, I was a volunteer on Rikers, and I used to run health education groups. And so I'd actually learned secondhand from patients about their healthcare experience while incarcerated, and that would help me figure out, this isn't going to work. Like when people come out and are released, they need a different way to approach care. And so that's really, I think all of those educational sessions where people had the chance to share, again, problems with the system or why they don't trust the system, that gives you a chance to troubleshoot and how can we make the system better? So that's what we do.
I'd like to ask you to provide some advice to the clinicians and community health workers in our audience. What are the challenges in identifying victims of abuse?
So I think that's really important because often it's a quality metric, right? Like, did you screen for abuse? Did we find a survivor or someone who's experiencing this? And I think it's really important that we have ways to ask that are thoughtful, that make people feel comfortable answering, but also respecting that sometimes people are going through the experience, but they're not ready to talk about it. That's okay. They still need health care. Mm-hmm. So you need to do something where even if someone doesn't disclose care, they can still get what they need without jeopardizing their safety. And I think that's why trauma-informed care practices are so important, because if people feel comfortable engaging and getting that hypertension med filled without their abuser knowing about it and they can pay for it, that's still health care, and the system did its job even if they didn't identify someone as a survivor.
So when medical staff discover a patient that lives in a dangerous situation, what are some of the steps they can take in helping a victim of abuse improve their living circumstance?
So I think a lot of it is for the clinical staff and the clinic system in general to be able to know the resources firsthand more than a printed out sheet. Like really being like, this is going to be a tough shelter system, but we know someone here, talk to them and figure it out. I really believe that what we've seen is personal connections, or at least helping people anticipate what the next steps are going to be, helps people be more likely to try things, especially if they're in a dangerous situation, because people don't always feel comfortable exiting, and we have to be able to respect that too and make it something so that they see why it's a safe option to leave.
So I think what I've heard is, you know, an enormous problem that we see across a wide swathe of society, quite often hidden.
Yes.
You're exposing it, you're bringing it to the forefront, you're providing tools and capabilities that allow people to really start to address this and bring it to the surface.
That's right. Yes, that's how we're going to improve care for that population and others too. I really believe that.
Anita, thanks for joining us
Thank
today.
you. Thanks for having me.
As we've said, NCQA is about quality in healthcare. We want to make healthcare better for everyone throughout the United States. Take a look. He's back. To wrap things up with us, Frank Micciche. He's the Vice President for Public Policy and External Relations at NCQA. Frank, another great quality talk show.
Awesome. Awesome. I say it every year, and it sounds like the party line, but it truly is every single year. The breadth of topics, the experience and the insight and the energy of the speakers, it's really remarkable. It is exactly what we have always intended Quality Talks to be, which is a day of inspiration. We do a lot of perspiration. We do a lot of the hard work. Even our conference in the fall is more focused on best practices and cutting edge things. This is about inspiring not only what we do, but why we do it. So it was another wonderful year.
So I think that's true, but I would call out something else. It's not just the inspiration, but it's also the practical application is what I heard repeatedly through some of the talks, some of the interviews. This is not just, hey, these are great ideas. This is here, these are great ideas, and this is what you can do to implement them in your space.
Good point. And I know that Andy, in curating our speakers and working with them, always asks them to have that call to action and to have something actionable about what they're relating to us. So you're right about that. I think you're a heck of a lot more likely to take action if you're inspired. So the two combined are great.
Absolutely, got to come together. So thinking back, you've been here. Hopefully you've had a chance to participate, learn, enjoy some of these things. Anything stand out to you particularly?
Well, I don't want to pick out any one speaker. Well, I will pick out one speaker, and I will say as I do that they were all terrific.
Sure.
But the gentleman from the Veterans Health Administration and his discussion of whole care, which is a concept that's out there in integrated health. And so not a foreign concept, not incredibly revolutionary, but the way he talked about it, the way he tied it back to statistically the effect of having or not having a purpose and being able to pursue that purpose and what that does directly in terms of life expectancy. That was powerful to me. And then the examples he gave of the veterans who've seen such an improvement in their lives as a result of the care that they're providing in that system was inspiring.
Right, and I think, we've seen the sort of digitalization, but specifically the health equity. I will tell you, just based on sort of audience response, I thought Dr. Nzinga had a very powerful talk. Yes. It obviously touched a lot of people based on what I saw.
Yes.
Tremendous programming. Any sort of final parting thoughts as you think about this year and perhaps future years?
Sure. I guess parting thoughts are that I will sleep well tonight, that we did well by our audience, in person and remote, because that's always a concern. Folks are giving us their time and in some cases their money to participate with us. I think we did a great job with that. I'll make the commercial pitch. Our Health Innovation Summit this fall is 3 days worth of this type of thing, although, as I said, we also get into best practices and those sorts of things. But it will be cutting edge, certainly, because we're going to be talking about these same priorities, digital and equity. And I think maybe one final thing is that I think the speakers intentionally or otherwise married equity and digital in a way that was really powerful and that speaks to the future.
I'm just going to say we're all going to sleep pretty well tonight. I know there's a big team of people that contributed,
Yes.
so you and me both, and I know a number of other people. Frank, thanks for joining us today.
Thank you, Dr. Nick. You're new to our team as host, and from everything I've seen and heard, you've done a wonderful job. So
You're very kind. Thank you. Thanks to Frank for chatting with me. And now let's thank our onstage host, Andy Reynolds, for joining us here at the live stream set. And of course, thanks to our NCQA colleagues, those who ran the event, and those who joined us for the interviews today. Remember to keep sharing your feedback with us. Find NCQA on LinkedIn and Twitter. Post your ideas on today's presentations and your answers to the thought questions I mentioned earlier. And again, remember, add the hashtag QualityTalks2023 to anything you post online so that we'll see it. We value your input. We can't wait to hear from you. We look forward to seeing you all in the fall at NCQA's Health Innovation Summit in Orlando. Register at ncqasummit.com. And that's Quality Talks 2023. For all the team here, the team in the ballroom, the team in the control room, a million thanks on a job really well done, and to you out there on the stream. Thanks for joining us. I'm Dr. Nick. I look forward to seeing you again in the fall.